Good morning, everyone. I kindly ask that you take your seats. We're about to start in just about 1 extra minute. Thank you so much.
Good morning, and good afternoon or good evening for those who are joining from all around the world online. Welcome to the Harvard Global Health Institute's 3rd annual symposium. I'm Louise Ivers. I'm a professor here at Harvard Medical School in Global Health and Social Medicine, and I'm the director of the Harvard Global Health Institute. So my team and I are your hosts for today. We want to thank all of you, our guests, who are here with us in Cambridge, Massachusetts, and wholeheartedly welcome you. Thank you to all of our speakers. Thank you to all of our participants for spending the day with us and bringing your expertise to the discussions. We are also streaming this event, and we have about 2,000 participants from all around the globe listening in. Thank you so much, and watching. Thank you so much to you all. Harvard Global Health Institute is a university-wide endeavor that serves as a kind of connecting tissue between the multitude of global health activities across the university. Recognizing the manifold and multi-sectoral challenges facing our global society and local communities, we firmly believe that working together is indispensable for progressing towards achieving health equity and health for all. In a time that's marked by somewhat unprecedented change and a lot of uncertainty, the need for empathy and collaboration has never been greater. As we embark on today's conversations under our theme of delivering on the promise of health equity, we find ourselves at a pivotal juncture where the urgency to act has never been more pressing. We already had a lot to do. Now in the US, we're seeing a retreat from global solidarity and a deconstruction of systems of global engagement and collaboration. And I, for one, am very concerned about that. But it is especially in that context that we at HGHI are proud to be convening a multi-sectoral, multinational discussion today of free and open dialogue to exchange ideas. I encourage us all today to move forward with a renewed vigor to action. And as we discuss and engage today, to ask ourselves, what must we do? And what are the most important things that we must do in this moment? So welcome to the conversation. We look forward to engaging with you throughout the day. I have a few things to tell you, which is that we have time built in for questions from both our in-person and our online audience. If you're here in the room, you'll just be able to raise your hand during the Q&A session. We have some microphones. If you're online, there is a Qualtrics form linked into the YouTube Live, and you can submit your question that way. To permit us to spend most of our time in conversation, our introductions to our esteemed speakers are quite brief. So we'll encourage you to use the QR code on your table to learn more about the bios of each of our speakers. And this event is being recorded, and it'll be made available on the HGHI website in the days to come. So now it's my distinct pleasure to introduce Dean George Daly, who serves as the Dean of Harvard Medical School and is the Caroline Shields Walker Professor of Medicine. Dean Daly is a physician scientist and a renowned authority on cancer biology and stem cell science. Dean Daly is trained in internal medicine, hematology, oncology, and a longtime member of the HMS faculty whose work spans the fields of basic science and clinical medicine. He's a professor of biological chemistry and molecular pharmacology. He's an incredibly strong supporter of global health endeavors, and I'm delighted to welcome him to open the event. Thank you, Dean Daly.
Thank you so much for the QR code and the, yeah, these gatherings that Louise and HGHI organize are always extremely important. I cannot imagine a more important time for bringing you all together. So thank you, Louise, for that. You know, it's actually, it's events like these that I think provide a solve for us all in these difficult times. There are tremendous challenges globally. We're feeling them all. And we benefit from coming together and sharing our experiences and identifying core issues that we can do, that we can affect. So I want to say that I am very proud that this symposium really reflects some of the strongest values that I believe Harvard holds. Integrity, openness, humility, despite what some would say about us, service, despite what some would say about us, compassion, and most importantly, equity, health equity, which sadly has somehow become a beacon term that draws attention to grants that should be canceled. It's a Orwellian kind of conundrum here. The fact is that Harvard Medical School, and in particular the mission of the Department of Global Health and Social Medicine, which was led for so many years by Paul Farmer, who was a major champion of global health equity, and for which we have really adopted global health equity as a core part of the whole Harvard Medical School mission. It's not just an option that we choose, it's an imperative. And I know that all of you share that objective, and it's the reason that you're also heavily engaged with some of the most important work that there is on the planet. So throughout today's symposium, you're going to hear from experts who are really delivering on the aspirations and the promise of health equity from a variety of perspectives, using a variety of tools. And I hope that you're going to find some hope and some inspiration in their stories. So one such speaker is the author and philanthropist John Green, whom the Harvard Medical School professor of Global Health and Social Medicine, Carol Mitnick, is Carol here? Not here yet, but apparently she's set up to interview about the online social movements and how they can advance the cause of global health equity. So Mr. Green has a new book out titled Everything is Tuberculosis, the history and persistence of our deadliest infection. In the book, he notes that in 2023, more people worldwide died of tuberculosis than died of malaria, typhoid, and war combined. That's saying something. He correctly calls this a tragedy, argues that from a policy standpoint, it's been a choice to let people die of this highly treatable disease. So I think there are very few excuses why we shouldn't be fighting it. And unfortunately, choices are being made not to. So we're seeing choices taken at our federal level to back out of our commitment to global health leadership. The United States withdrawal from the World Health Organization, impedes our ability to detect, respond to emerging disease threats. It means we will lose access to important data shared by member countries. Global infectious disease is a national security issue. Furthermore, the administration's choice to gut the U.S. Agency for International Development means that more women across the world will die in childbirth, more children will die of pneumonia or malaria, more malicious forms of infectious disease will develop and spread. Global infectious disease is a national security issue. I was recently at an event, the Breakthrough Prizes on Saturday night, where breakthrough science is celebrated in the setting of Los Angeles with lots of the Hollywood stars. Bill Gates was there, and I had a chance to talk with Bill. And he shared his consternation about the disassembling of a lot of the USAID infrastructure, which the Gates Foundation partners with in many settings for the delivery of HIV and TB drugs. And even a foundation as powerful as the Gates can't make up for the loss of that infrastructure, which he was bemoaning. So I think today we have to choose to think creatively and collaboratively about how we can fill this void. We can choose to remain undeterred in the difficult tasks in front of us. We can choose to continue to advocate unabashedly for the importance of global health equity and for equitable partnerships that leave countries feeling more stable, more supported, and ultimately more free. It's an issue of national security. And indeed, we can choose to work toward multidisciplinary approaches to global health service and delivery, care delivery. We can continue to address the social determinants of health, which lead to health inequities, to strengthen our primary care systems here in the US and around the globe. And indeed, we can control the things that we can control, and that is all of the passionate work that you all do to advance global health equity. And these are the choices that we can control and we can make. So I just want to extend my tremendous gratitude to all of the efforts of the Harvard Global Health Institute, all of you, all of the researchers that come together, the students, the faculty, the staff, for all of the important and good work that you do. It's important. It's a matter of national security. So as Buckminster Fuller once said, my wife used to work for Bucky, and she repeats this frequently, we are all one people on this very tiny spaceship Earth. There is no world in which we are not accountable to one another, in which our cooperation is not absolutely paramount. And so through the Global Health Institute, we don't just study global health challenges, we actively model the global cooperation that is needed to solve them. So thank you, and please enjoy and learn from all of today's presenters. Thank you very much. Louise.
Thank you so much, Dean Daly, for those very inspiring comments. I have the pleasure now of introducing our keynote speaker for this morning, Dr. Rhonda Seeley-Thomas. Dr. Seeley-Thomas is Assistant Director of the Pan American Health Organization, PAHO. She is a medical doctor, has a master's degree in public health and a doctorate in public health from the University of the West Indies. She's held numerous leadership positions in the health sector. Prior to her appointment at PAHO, Dr. Seeley-Thomas was Chief Medical Officer for the Ministry of Health in Antigua and Barbuda and was the Chief Technical Advisor to the Minister of Health on all public health matters of regional and international concern. Welcome, Dr. Seeley-Thomas. Thank you so much for being here. We're looking forward to your comments.
Thank you, Louise. Dr. George Daly, Dean of Harvard Medical School, Dr. Louise Ivers, Director, Harvard Global Health Institute, distinguished guests, esteemed colleagues, students, and dedicated champions of global health, good morning, and thank you for allowing me to address you. It is both an honor and a privilege for me to address such a distinguished gathering of individuals committed to advancing health equity. Today, as we gather at this vital crossroad of science, policy, and human rights, we must ask ourselves, are we truly delivering on the promise of health equity, or are we merely inching forward while millions continue to be left behind? Health equity is a fundamental component of social justice that indicates the absence of avoidable, unfair, and remediable differences in health outcomes among groups of people due to their social, economic, demographic, or geographic circumstances. It denotes that everyone should have the opportunity to obtain the highest level of health. As public health professionals, we should see health equity not merely as an aspiration, but as our obligation working towards ensuring that every person, regardless of where they live, their socio-economic status, age, race, ethnicity, gender, or disability, has an equal opportunity to achieve their highest standard of health. Despite remarkable advancements in health policy, medical breakthroughs, and technological innovations over the past decades, including the development of new vaccines, medicines, and AI applications in healthcare, vast health disparities persist. For example, a child born in the region of the Americas where I am from, particularly in Latin America and the Caribbean today, there is still significantly more likely to die before his or her fifth birthday than a child born in Norway. Moreover, the maternal mortality ratio in the region of the Americas is over 5 times higher than that in Europe. These differences in health outcomes are a stark reminder that we have not yet fulfilled the promise of health equity in the region of the Americas. So why is it that despite global resources and innovation, the health equity gap persists? Answers lie in structural inequities in wealth distribution, systemic discrimination, and underinvestment in primary healthcare systems. The fragmentation of global health governance and the commercialization of health delivery have only exacerbated these challenges. Latin America and the Caribbean is the most inequitable region in the world. The health inequities that plague this region and prevent us from moving towards more just, inclusive, and productive societies are inextricably linked to deeply entrenched inequities in other dimensions, such as income inequality, unequal access to quality education, decent work, and social protection and adequate housing. The wealthiest 10% of the population in Latin America and the Caribbean earn 12 times more than the poorest 10%, a contrast to the ratio of 4 in developed countries of the Organization for Economic Cooperation and Development. Between 1990 and 2014, the region of the Americas experienced a reduction in income inequality. However, progress since then has stalled, in part due to the serious economic impacts that resulted from the COVID-19 pandemic. The intergenerational transmission of inequity is particularly worrying. Being born in a low-income neighborhood, belonging to an ethnic or racial minority group, and having parents with limited schooling or low-paying occupations all contribute to trapping future generations in cycles of poverty in our region. These cycles of poverty, inequality, and inequity, and a lack of social mobility directly influence health outcomes in the region and prevent many from accessing the resources they need to lead healthy lives. The COVID-19 pandemic further exposed these long-standing inequalities and inequities. The region of the Americas was particularly affected by the pandemic, accounting for 25% of all cases and 43% of all deaths, making it the region with the highest number of COVID-19 deaths worldwide. structural inequalities such as high levels of labor informality, weak social protection systems, and fragmented health systems all contributed to this crisis and illuminated the urgent need to address inequities with meaningful long-term solutions. Permit me to highlight a few examples in the region of the Americas where health inequities exist and how PAHO, Pan American Health Organization, is working to eliminate them. As a background, PAHO is a specialized international public health agency dedicated to improving health and well-being across the Americas. Established in 1902, PAHO has a dual role. Firstly, it is a specialized agency of the Inter-American System, and it also serves as the regional office of the World Health Organization, or WHO. While PAHO forms part of the UN system and inter-American systems, it is important to highlight, particularly at this time, that it retains a special, unique, and separate legal personality and decision-making authority from both. In its origins, PAHO reported on sanitary conditions in seaports, maritime quarantines, and the control of infectious diseases. In 1920, it expanded this role to health promotion. Today, PAHO is involved in supporting countries in the prevention, control, and treatment of a wide range of health issues, including non-communicable diseases, including cancer, demonstrating the organization's ability to transition and adapt to a changing health landscape. And I'm sure you'll agree with me that that's a skill that we need to dig deep and strengthen, given the changing political and global landscape. PAHO's work has also focused on improving the quality of life in countries of the region and underscoring the clear link between health, social, and economic development and political stability. I'd like to highlight 4 key areas where health inequities exist in the region and illustrate how PAHO is actively working to address them. Firstly, regarding maternal mortality, approximately 7,800 maternal deaths occur each year in the region of the Americas, equivalent to almost 1 maternal death every hour. While there was a reduction in the maternal mortality ratio between 2000 and 2023, the region had the smallest percentage reduction in MMR in any world region during this time period. The inequity that is faced in our region with regard to maternal mortality is further illustrated by the fact that women living in rural areas and poorer communities, those with lower levels of education, and younger adolescents, those 10 to 14 years of age, face a higher risk of complications and death as a result of pregnancy. The leading causes of maternal mortality in the region are high blood pressure and hemorrhage, which can be prevented, detected, and managed adequately given the advances in medical technologies and diagnosis. Most maternal deaths that occur in our region are preventable through improved access to quality health care, contraception, and reduced inequities linked to cultural differences, poverty, and a lack of good education systems. In response to the increasing maternal mortality rates in the America, PAHO has launched a strategy for accelerating maternal mortality reduction in the region based on primary health care. In June of 2024, it focused on improving access to quality care, reducing inequities, and addressing the underlying social determinants of health. It emphasizes expanding and strengthening primary health care, prioritizing territories and population groups most at risk of experiencing maternal mortality, intercultural care, and intersectoral collaboration to ensure the health and well-being of women across their life course. Cervical cancer is a second condition that exposes these health inequities in our region. Although it is preventable and curable if detected early, it remains one of the leading causes of cancer-related deaths among women in low and middle-income countries. This is particularly concerning, since despite having the tools available to prevent, detect, and treat, and eventually eliminate cervical cancer as a public health problem in Latin America and the Caribbean, mortality rates are 3 times higher than in North America. Disparities also exist within countries, particularly among indigenous women, who face structural, social, and cultural barriers to access HPV vaccination, screening, and treatment. PAHO is supporting efforts to eliminate cervical cancer through comprehensive strategies, providing assistance in developing national cervical cancer elimination plans in countries of the Americas, supporting the implementation and scaling up of programs such as single-dose vaccination schemes and the use of human papillomavirus testing as the main cervical cancer screening method through our regional revolving funds, a mechanism that allows our countries in the region to pool their resources to access HPV vaccines, HPV tests, and equipment for treatment of precancerous lesions at a low cost. Through this mechanism, we endeavor to bridge the equity gap in cervical cancer and ensure that all women, regardless of age, place of residence, ethnicity, or socioeconomic status, have access to cervical cancer prevention, detection, and screening technologies while recognizing the critical role of culturally sensitive education and outreach, community engagement, and empowerment strategies for women and girls in situations of vulnerability. Thirdly, in Latin America and the Caribbean, over 29,000 children and adolescents are diagnosed with cancer annually, with 10,000 dying, representing the second leading cause of death in this age group. While over 80% of children with cancer in high-income countries survive, in our region, only 20% in low and middle-income countries survive. Due to a lack of diagnosis, misdiagnosis or delayed diagnosis, obstacles to accessing care, abandonment of treatment, death from toxicity, and higher rates of relapse. In partnership with St. Jude's Research Hospital and ministries of health across the region, PAHO is working to address this gap. Through the Global Initiative for Childhood Cancer, we are supporting countries to develop national childhood cancer plans, improving access to care, ensuring the availability of essential medicines, and strengthening pediatric oncology training. A technical package called Cure All is guiding the development of these national childhood cancer plans and interventions. Activities include supporting clinical care for the most vulnerable children, ensuring that all children with cancer have access to high-quality medicines and technologies, strengthening training programs through the development of centers of excellence, and supporting the development of care coverage regulations and treatment and monitoring tools. The PAHO revolving funds once again contributes to this endeavor by ensuring the availability of essential medicines. By 2030, we aim to achieve a survival rate of at least 60% for 6 of the most common types of childhood cancers in low and middle income countries in our region. The fourth and final area I'd like to highlight is the situation with neglected tropical diseases, or NTDs, which disproportionately affect populations in situations of vulnerability, exacerbating existing health, gender, and socioeconomic inequities. During the last decade, PAHO has been actively working to eliminate NTDs in the Americas through initiatives that focus on addressing health inequities by bringing prevention, diagnosis, and treatment closer to communities, especially those that are most marginalized, including indigenous and those in remote areas in the Americas. One of the priorities of our disease elimination initiative that aims to eliminate over 30 communicable diseases, including NTDs, and related conditions in the region by 2030. The initiative promotes an integrated, sustainable approach to accelerate progress, leveraging technical cooperation, research, training, and the donation of medicines and diagnostic tools to those in need. With the technical support of PAHO, the Americas has achieved significant milestones during the last decade in NTDs, including the elimination of onchocerciasis in Colombia, Ecuador, Guatemala, and Mexico, and more recently in 2024, the elimination of lymphatic filariasis in Brazil. In addition, PAHO has been working towards the elimination of trachoma, a leading cause of blindness in countries such as Brazil and Guatemala. By focusing on health equity and leveraging innovative strategies, PAHO is making strides towards a future free from neglected tropical diseases in our region. Ladies and gentlemen, the future of global health is not written in stone. It is shaped by the choices we make today. Even in the face of substantial challenges, we must uphold the values of equity and health as a human right. All pregnant women deserve the right to a safe pregnancy, delivery, and postpartum care in a setting that is suitable to their cultural and other unique needs. The children that they bear deserve the right to survive. Economic, geographic, and political barriers to treatment options should not hamper their survival from diseases such as cancer, trachoma, and other neglected tropical diseases that can be detected early, treated effectively, and in many instances cured. Delivering on the promise of health equity can be realized if we act with intentionality in three critical areas. Firstly, strengthening primary healthcare systems. By investing in community-led solutions, bolstering health infrastructures, and prioritizing preventive care and health promotion, for example, for cervical cancer, we can create sustainable change. Secondly, promoting equitable innovation and technology. The advancements in artificial intelligence, telemedicine, and vaccines and new medicine development must be deployed inclusively, rather access for all, not deepening existing divides. Thirdly, addressing the social determinants of health, improving education, income inequality, housing, employment opportunities, and access to social protection are essential to reducing health disparities in the Americas. As Dean Daly said this morning in his remarks, we must think creatively and collaboratively to address health inequity in the region. As we gather today and as we leave this symposium, let us move beyond the rhetoric and towards action. Let us challenge outdated models, build alliances to achieve common goals, and continue to work to deliver the promise of health equity into a reality for all. Thank you for your attention.
Thank you, Dr. Seeley Thomas, for your reflections and setting the stage for a day filled with insightful conversations. My name is Carol Lucy. Good morning, everyone. I'm the Associate Director of Programs for the Institute. We're very happy that you're here with us today. And we have a pleasant surprise and a rare treat at a conference. We have run a little bit ahead of schedule. So I will invite you all to please connect with one another for about 15 more minutes. We have some breakfast for you as we get ready for our first panel of the day. So thank you so much. And when you hear my voice, it's time to come back. And for those online, please take this time to take a break, and we'll be resuming shortly. Thank you.
know you and love you very much. How are you doing? How are you? Keeping out of trouble? Yeah, I know. Me too. Too much out of trouble, but that's how it goes. Very tired. You always got to make those sacrifices. Oh, yeah, you mean, yeah. He's taking care of it and medicine. That's what he told me. And I didn't know what he's going to do with it. It's okay, yeah. Wanted to help him. You know, now that they have to do something, it's going to go on. Yeah. How are you? I'll give you a hug. I just didn't recognize you that much. We're trying to have a partnership. Oh, wonderful. This woman's the history major for all planet, let me tell you. Oh, let me, I'll never forget that. That's right. It's time for another similar moment in my life. You see? You see?
Two, two.
We wrote AIDS in Botswana. I mean, in Africa, but now we need. Yeah. Well, South Africa, you know, leadership. It's a woman. And when she takes over, a lot of things happen. Oh, no. That's called. It's short. They got select where we cut, but they always paid for their own. So they are protected. I mean, they're not going to get the program. It's always so bad on every level. They're they are. And this discussion, it all started to look south and say inequities and disparities unaddressed. We started to address them. Every drumbeat that brought it out of a government response to lose the response. Yeah. I could recall. Yeah. Okay. No, he's not. He's with me. Oh, that's okay. That's all right. Converge. Listen, you have no excuse. You don't need to make an excuse. All you have to do now is get through. Right? Most of us. Even the one who comes furthest. Go ahead. Anyway, fellas, who's writing the book? Because I really, tell them to talk to me before they're going to bed. I know. Right. some of that. Very good. You can do it.
And Ed on Twitter. We'll see you guys.
Hello, hello. This one is not on. Hello, hello. If you could make your way back to your seats, we're going to resume shortly. You are a very responsive audience, may I say. Thank you so much. And I'm just allowing the online audience to get back to their seats, wherever they're watching us from. Good morning again. Thank you for your patience and flexibility as we're running a little bit ahead of schedule, as I mentioned earlier. We're very excited to introduce our first panel entitled Displacement and Disparities, Navigating Health Challenges Amid Conflict. This session is being hosted in partnership with the Harvard Humanitarian Initiative. Giving opening remarks for this session is Michael Van Rooyen, Chairman of Emergency Medicine at both Massachusetts General Hospital and the Brigham and Women's Hospital, Enterprise Chief of Emergency Services for the Mass General Brigham System, and founder and director of the Harvard Humanitarian Initiative. Dr. Van Rooyen, please take it away.
Thank you and good morning. I'm going to take off on a theme that you've already divined as a theme for the day. Prior to January 2025, the prevailing dialogue in the humanitarian sphere where we work has been in how to protect populations, how to access populations, how to find and serve populations in crisis, how to empower organizations to reach organizations to preserve human rights and to prevent human suffering. That dialogue changed in January because suddenly now we're faced with, I wouldn't say even more of a crisis, but another crisis. And that is this rapid retraction of humanitarian funding from not only USAID, but from the world, because we see other development dollars going down as well, has left the humanitarian sector in disarray and in crisis. And these organizations, their job, their goal, their mission, and their passion is to care for the world's most vulnerable populations. And as a result of this rapid retraction that I think has been incredibly disruptive, aid organizations are trying to figure out what to do and trying to figure out how to take these rising humanitarian needs, face them, and care for the populations who deserve this. And let's be clear, without principled investment into the humanitarian sector, the world will become a more dangerous place. It is becoming a more dangerous place, right? Out of the 300 million people that suffer from, require humanitarian assistance, from the 100 million that are suffering from displacement around the world and from those who are on the brink of actually death, we're sort of pushing that over. And it's a critical time. And so this room, and largely the audience of 2,000, which is phenomenal, listening today, have two choices. Your choice is to throw up your hands and say it's all terrible, because it's really easy to do that. Or it's to fight this, and fighting it meaning invest in our people, in our programs, in our organizations, in our NGOs, in our UN agencies, in the organizations that do this work. And it is a time not to sit back, but a time for leadership. But it takes principled, dedicated, creative leadership that risks a lot in order to preserve this mission. And so we're here with people who think about this. And so I'm really delighted to introduce this panel of humanitarian leaders in the current era, because they are going to be talking about the large panel online and in this room of humanitarian leaders of the future. And so it's my pleasure to introduce this panel and to introduce our, oh, wow. That's good. So bust into song there, that's good. And so let me just introduce our team here, and we're delighted to have them so far as well. Thank you, Dr. Leaning. I just was talking to Jennifer earlier today that I went completely digital, and she's still analog. And so analog apparently works, so it's good. So the panelists, and I know them all anyway, so it's great. Petra Curry, who is a friend and colleague, a doctor of pharmacy, global director of health and care for the International Federation of the Red Cross and Red Crescent. Thank you for coming. Salman Khashoggi, who's the director of the Harvard Medical School's Center for Global Health Delivery and a professor of health and social medicine. Great to see you. And Dick Chamla, who's also a friend and colleague, who is the head of emergency preparedness for the African region of the WHO, all really experienced leaders, all in a little bit different areas of focus, and all can really lend a lot to this. And then, it's my great pleasure to introduce my friend, colleague, and co-founder of HGHI, Dr. Jennifer Leaning, who has a long career in humanitarian work around the world and is a senior fellow at the FXB Center and a professor of the practice in health and human rights. So I'll turn it over to Dr. Leaning to take over the rest of the panel, and thank you all for attending today. Cheers.
So Dr. Van Rooyen, Mike, to a number of us, that was a wonderful introduction, and it spared me from repeating what I would basically like to underscore, which is that we have, the four of us together, we have talked 2 to 3 times in preparation for this event. And I have encouraged them, although I didn't need actually to offer much encouragement, although they might have been prepared to be more zipped up and more cautiously political in this talk and in this framework, and even more so with 2,000 people online. But I still believe it's important to be speaking truth to power. It's really important. And at various times in Harvard's history, it has done a good job of doing that. At other times, not so good a time. And we're basically watching how universities will manage to stand tall, find the funds, and not get their heads cut off because they're standing above the grass. But it's actually that stark. And if it feels stark to us here in this beautiful building with wonderful colleagues and staff, great coffee, I might say, if it feels arduous to us as we're looking forward, what to teach, what to train for, what to aspire to in your career, we have here 3 deeply seasoned people who are beautifully trained in their own traditions, which basically come together in humanitarian work, medical and epidemiologic humanitarian work, vast experience in different countries. I will allow them to say a bit from what power base they come from. And you all have power bases. And the order that I am introducing you to speak, Petra, Dick, and Salman, I hope is okay. Mike Van Rooyen thought it was okay, and others did as well. Is that all right with you, if we go in that order? And partly, Dr. Curry, I know that you have a very tough perspective from the standpoint of being senior in an international organization that has been doing humanitarian work for decades, and a century and a half, basically. And this is, there was World War I, which was arduous, and World War II, which is arduous, and now there's this time. And so from that perspective of how agonizing it is, could you please share your thoughts?
Sure. Good morning, colleagues. Thanks for listening. Maybe we go back in history a bit. I mean, we have to learn a bit from the history so that we talk about the future. The Red Cross, Red Crescent movement started 160 years ago, and there is a reason why it started. It started because of a battle in Italy, Solferino Battle, where 10,000 soldiers were left to die, and no one would come forward to treat them with fear of retaliation and fears of being labeled on one side of the conflict. And it was this man called Henri Dunant, who's a Swiss philanthropist. He was on his way and he saw this. And what he did, he went to the neighboring villages. He called on the women, not the men. And he asked the women if they can come forward with him and walk and give relief to those 10,000 injured soldiers. And he flipped the Swiss flag. That's why it's called Red Cross, because the Swiss flag is a white cross. So he flipped the Swiss flag and he walked forward. And since then, the mission has started that we need a neutral, impartial, humanity, independent entity that serves under different conditions and provides humanitarian service. Fast forward to 2025, where we are. The current status of what I've at least observed, I've been visiting capitals since the beginning of the year, and I have to say probably the US is the headline, but similar things are happening elsewhere. It's not only the US. And others possibly are doing it under different approaches. The US approach was the most flagrant one. They immediately pulled out the Band-Aid, but others have been doing it. And the status of my reading, at least, of the status of the world, and particularly on the global health side, attitude towards global health has completely changed. We go back 1 year ago, the attitude of governments towards global health was a bit different from what it is today. And specifically, foreign aid. When we talk about foreign aid, it has suddenly become a trade tool or a business deal. And they're lumping foreign aid with humanitarian aid. We're trying to make the distinction that foreign aid has always been an instrument of government to do political influence. Humanitarian aid, to some extent, has been shielded and guarded. That's not the current attitude. The other issue about attitude, the public attitude towards foreign aid and global health. Suddenly, this misinformation, disinformation that has been brewing since COVID time has peaked. There is a general attitude that why do we need to support people that are outside our borders? We need to keep the money internally, and all of these investments that have been happening for years are not to our best interest. It's probably the line of political influence. The second, so attitude is the first. The second one is complete disregard to the commitments that governments have done, whether to SDGs, to laws, to resolutions. Every year, ministries of health gather at the World Health Assembly in Geneva. We celebrate resolutions at the UN General Assembly resolutions, events, and now we're resetting. We're doing all of those changes, and we're not looking at the goals that we have committed to in 2030. It's as if all of this conversation is completely gone. So the complete disregard, not only on the health side, but also on the humanitarian side. I think in the last 3-4 years, the complete disregard to IHL, the way the rules of the wars, the impunity that has risen, there is an attitude of disregarding the world order and commitments on it. The third one is the stark reality that we're currently seeing. When the Western funding disappeared, capacity also disappeared with it. And this is a reflection to us as agencies that have been working in this space. I mean, we have reports that says possibly 50% of the health capacity in Africa will be gone with the Western defunding approach. So this is for us to look at the mirror and wonder, did we do things at the best as we should have done them? Or could we have done things differently? And that's part of the solution and talking together on the way forward. Do we want to go back to January 19, or should we look at something different? And obviously the last one is commitments to ODA. Governments had made commitments that 0.7% of their GMI would go to ODA. They're not gonna. There are only two governments currently, they're committing to this 0.7. They're Denmark and Norway. Every other government is dropping its commitment. The latest was obviously the US, completely not there, but the latest, the UK, they dropped it from 0.7 to 0.5 and now 0.3. So we're going further down. And the last point, and I'll pass it over, the estimates that we had done before the US funding cuts were around 21.7 billion of ODA funding will disappear in the next 5 years. This all comes at a price. This all comes at what we're going to do and where are the priorities going to be. Thank you.
Thank you very much. We're going to engage further with you in the Q&A and the back and forth, but the historical overview is very appropriate. And we're going back to a time when, notions of triage were just being developed in the 19th century. And we're going back to a time when a humanitarian who was not a physician noticed that there were, on that battlefield, soldiers, men, who were dying of thirst and bleeding, and sometimes covered partially by the dead horse. There were many dead horses. And he saw this and managed to discern that there was agency that he could deploy with help. So I think it's an image we need to come back to when we think about how humanitarians are going to pick themselves up, and with that, pick others up. So thank you. So next in order, Dr. Chamla, could you speak to us about your perspective, which is actually, you have multiple perspectives. So you choose how you want to position yourself.
Anyway, I'm from Africa, and also I'm from WHO. I'm from Africa. As I'm talking now, we have over 80 emergencies happening in Africa. And I'm only talking in April, okay? 2024, we had over 128 emergencies in Africa. And around the 20% are humanitarian crisis. I'm talking of the wars we have in Sahel region. So we have now another war in which is happening in the DRC Congo. And we have others in which actually have emerged. I don't know if any of you understand, 2 days ago, we are having a crisis now of the Mali and Algeria, in which is already starting. And we have a closure even of our airspace at the moment. It is Africa. And I'm saying I'm also from a WHO, because if you have all heard, United States has targeted specifically WHO to withdraw. And as a result, I'm here now, I'm having two hats. I'm from the region in which we have inequities over years, highest maternal mortality happening in Africa, the higher rate of public health emergencies and conflicts happening in Africa. And also now we are having an impact in which we have an abruptly cease of United States assistance. And from our preliminary assessment, we are clear now. We understand over 24 million people in Africa who are living in crisis will have the lack of access of health care. And we will have displacement. And I always tell the people, at the time we have a population in displacement, we also have health workers who are also displaced, okay? As we've had here, capacity issues. Here is also a capacity issue. Another issue in which I'll be also interested to be talking up here is if you analyze the initial impact, is actually international agencies in which are actually heavily impacted. As a result, is slowly we're starting to see a threat of the multilateralism. And a threat of the multilateralism, you have heard here is an international global health architecture in which it was created over 80 years ago. Okay, breaking it abruptly, actually it has its own implications, okay? As a result, and the problem is we are breaking it and we don't have an alternative to substitute, okay? As a result, we will be ending up with global health chaos at the end of the day. And I heard here the people were talking abruptly, seas of United is a crisis. It isn't only a crisis, it is a catastrophe. In Africa, we have programs in which are heavily dependent on US, HIV. Yes, with TB, we've had it here in the morning. So we have malaria. And in Africa, we had an excellent progress toward SDGs, as you have heard here before. And our worry is we will have actually a reverse of a progress toward SDG and actually progress in the elimination of actually a number of the diseases. And if we talk here on the issues as access to ARVs, we had PEPFAR, it was USAID. It's actually ending now, supporting to Africa. And the ARV impact on opportunistic infections, including TB, it was actually enormous. And as clinicians, we actually recall at the time of the heydays, at the time we have actually a pandemic of HIV here, we had clinical staging of HIV in which we had Kaposi sarcomas, whatever. And actually we ask it in Africa, we don't have it here now, okay? Yeah. And with abruptly stop of ARV, we are returning there again. And we will have issues here actually in the future. Okay, now I have another area in which we are actually not talking about. We've touched it a little bit here, Petra. And it is on the attacks of healthcare workers. I'm sure all of you have heard what is happening now in Ukraine, in Gaza. Actually, health workers are every day attacked nowadays. And the statistics are really dire. Actually, every minute a health worker is attacked in the world, okay? And if we are talking of health workers attack, we're always talking in relation to conflict, not actually. We also have healthcare workers attack in public health outbreaks. In Malawi, we have realized, because on how we are handling actually on the dead bodies after the outbreak of the cholera, actually we have the body bag in which are black, we spray it with the chlorine. It is actually against a religion and culture. And we had actually health workers who were actually even attacked. At the time I was in Afghanistan, I spent 2.5 years in Afghanistan. I was actually present at the time Taliban is taking over, okay? And it was also interesting. It was interesting because at that time we were organizing a campaign of the polio. Health workers were attacked too because of issues associated with Osama bin Laden and others, okay? And on the last point here, I'm talking, there's actually 2 points. On the last one, on the issues of the impact, in Africa now I wouldn't say we actually used to. At the time we had a pandemic, actually they already left us alone in terms of access of PPE and the vaccines, okay? As a result, in Africa, it isn't really new. And also at the time I was in Afghanistan, we saw it also. It's where the Taliban has taken over, and entire international community stopped. And remember, at that time, we were implementing a contracting out mechanism in health. It means NGOs were having the money, almost $200 million every year, from the World Bank, supporting healthcare. And it all stopped immediately. And we really struggled at that time. And also we had the moral issue at that time. So we had actually the choice either to try to help the population in need of humanitarian crisis or actually collaborate with the Taliban, a non-state actor who has a track record of abuses of human rights, in particular on women. The result, it was interesting time at that time. Actually, the issue we have now, how do we do about it? And in Africa is an issue we've been talking now. We are slowly thinking other people are taking a global crisis we have as an opportunity as well, an opportunity of reforms. As you have heard now, actually humanitarian architecture is reset. We have an opportunity now of telling our government increasing domestic allocations from its own budget. And also we have another opportunity to actually strengthening the regional institutions in which we have. Actually in Africa, we have African Union agencies now in which are starting to come up strong. We have Africa's CDC. We have African Union Humanitarian Agency now. It is already created, okay. At the same time, WHO and other agencies will be reforming slowly or actually in high speed. We don't know at the moment. In the WHO, we will have to, as you know, the last year, the contribution of United States, actually in the WHO, the budget is around 20%. Actually, we don't have 20% anymore now. Okay, therefore we will have to actually to adjust. In Africa, in the last biennial budget, United States it contributed around $180 million, and up to around 30% it was supporting emergencies, including mpox particularly. Okay, actually it has already now gone. Okay. And we will really have to think as an option. Where the multilateral banks, we've been talking about it. African Development Bank is starting to come up now with improving of health infrastructure. Therefore, we don't really see the impact up to now. So we have other ideas at the moment to see how about the private sector. From literature, we understand there is almost 200 trillion US dollars actually in the hands of the private entities.
Are you speaking in Africa?
Globally.
Okay.
Africa, 210 in private, I doubt. Therefore, how do we actually have access to that? We don't have an answers now. And the last point here is we've talked of EU, as an alternative. We have realized it won't work now. We have Ukraine war. The budget also is reducing. Okay, as a result, our options are limited, and it's an issue in which I feel how we'll be talking. Thank you so much.
You've done a rapid sweep of the globe, really. You didn't mention South America, but it is. But you could have. I'm quite sure. The sweeping disarray and the rapid rise of old and new crises is really upon us. And the options are, some of the options haven't actually been explored, but the ones that people on this panel know about and have explored, the options are pretty limited. So our third speaker, and we do have time, but I'm going to want to have questions from the audience and come back for you. So Salman, can you talk to us from your perspective? of the decline and fall, however you want to personalize it.
Yeah, so I'm grateful to go third because our colleagues have said such wonderful things, and I will be short.
Not necessarily, just concise.
Be concise. Obviously, we've had a number of conversations about this panel, and obviously this is something that's been on all of our minds for a while. And, I start to look back at this kind of change in moral orientation towards the sanctity of life, towards caregiving to other people. And I wish we could point to January 20th because it would be a nice, clear marker, but I think it starts well before that. And I think in particular about the wars in Iraq and Syria. And without going into the details of the war, you know that many people died and hospitals were bombed, health workers lost their lives, I think 1 million children in the first Iraq war, et cetera. So I'm not going to belabor that point, but it was, we've gone through some very incredible events where decisions were made that, it's worth life to do X. And I think at around the same time, it's given rise to an erosion of the international rule of law, and Petra, as you've alluded to, and I think in particular of something that we probably don't think about enough, but I have a student that's working on refugees that live on these Greek islands, that they're brought there as their first entry point into Europe. Many of them were telling tales about how their boats were boarded by EU frontier agents, their engines were disabled, and they were towed to the current that supposedly would take them to Turkey, and they were left to drift at sea, boatloads of refugees. I think about when I was invited by our colleague Michael Knipper to Germany to look at the situation of Syrian refugees who had walked across Europe. They had TB rates of 1,000 per 100,000 by the time they arrived, and had, again, these harrowing tales to tell in what are the most developed countries in the world. So, and of course I'm grateful that Germany was providing care. I don't want to knock them for that. They were thinking about how to deal with it. But it's, this did not start in 2016 or 2024. And, I've spent most of my career working with Partners in Health, 30 years, and a significant part of that being with Harvard Medical School. And we've been trying to deal with disparities and people's displacement from healthcare in different ways, not through wars, but just living in communities and dying. And just to put it into perspective, TB, the disease that I work on, and John just wrote a wonderful book about it, we'll hear more about it, that's, about 4,000 people or more die every day from that. So it's kind of stunning, right? And so when we think about displacement and disparity and the sanctity of life and the importance of not killing people because you have some other goal, that goal could be profit, that goal could be something else, that goal could be some outcome of a war. I think that has eroded over many, many years, and we've watched it happen in slow motion. And I think, when we were seeing kids put in cages at the border, obviously people were affronted by it, but it just went on. People elected a new president here in the United States, and the same, camps at the border, thousands of people waiting with an app to, get their asylum claims. 80 people a day or 100 people a day were taken on the app, and 50,000 people waiting. That just marched on, regardless of who was in government. So I think we really have to think about how historically deep this is, and this trend since the 1970s and 80s that have allowed for this degradation of I would say the moral order. There's a moral order that's degraded, and I think that's part of it. The second thing is that, if you look at countries in Africa and you look at countries in Asia, I actually, in this post-USAID period, I have, I think what we've seen is that we've lost a lot of the commodities that USAID was giving. I think PEPFAR talks about that, and the infrastructure that you've mentioned, Dick, that there was a mechanism to get commodities to places and for it to get to patients who need it the most. And I just this morning before this panel, I was on a call with the Ministry of Health of the Philippines in a project that Partners in Health is working on there to help them scale up TB care.
And it's interesting to see that this has kind of also changed the orientation of the ministries. The discussion was, in the absence of USAID, what money can the government bring to bear on making sure that people get their TB meds? And I feel like we weren't having this conversation 3 or 4 months ago. And I know that I'm talking about a middle income country, I'm not talking about an ultra poor country. There's a difference, so I'm not making a blanket statement. But there's that kind of glimmer in the background that you're like, okay, it's not gonna be perfect, but people are seeing that they need to rise to the occasion. And I don't know the mechanisms, Dick, you probably know it better, and Petra, you do probably as well. But I should imagine that when countries are having these types of emergencies, maybe they don't pay extractive loan interests at the same rate, and maybe they don't do other things because they can declare emergencies. And so I just wonder if this opens the door to a whole different game where people can say, we value the sanctity of life and we just don't want this many people to die, and so we cannot, we have to prioritize HIV medicines or TB medicines or diabetes medicines for that matter, or whatever it may be, right? So I think that there's that glimmer of hope in recasting this order. And then just the last thing I want to say is that, as we have to have some honest conversations about this, because we know that even with aid, we see outflows of large outflows of monies from places like Africa. And there's all these graphics that you always see with these big arrows coming out and little arrows going in. And so, we've kind of grown up with those graphics and take them for granted, but they're kind of part of the problem. We've also had Western countries, these wars, there's 35 wars happening in the world right now. They're not happening in a vacuum. They reflect some of the post-colonial tensions, but they're also fueled by arms sales from the very country we sit in and other places. So, this is, I think, a multifaceted thing, because the wars aren't happening in a vacuum, and the decisions to bomb hospitals or to kill health workers or to say, this is worth it and this is worth that, those are actually very political decisions. They're moral decisions, but they're political decisions. And so, it's not only in the United States, but in Canada and all of Europe and Australia and New Zealand and all these countries that are part of this have to really take us, and it could actually be in China and Thailand and Indonesia and Malaysia and around the world. People actually have to really be saying, this is not the moral path we want to take. And unfortunately, I think there's been a lot of kind of wait and see. And while the wait and see is happening, thousands of people are dying. I was on a call with people from the Eastern Mediterranean Regional Office of the WHO talking about emergency assistance just a few weeks ago. And when they were describing what was happening in Sudan, what was happening in Yemen with cholera, thousands of people are dying. So we think of Ukraine and Gaza and other places as flashpoints, and they're terrible flashpoints. But there's some other really terrible situations and facing the same situation. So let me stop there. Thank you.
Thank you. That was a good sweep of the world in terms of the complexities and the evolution of cracks and fissures, complexities and contradictions in the humanitarian world that has been created during these decades. And it's not refreshing, your account. It's not restorative, but it is a practical way to say it hasn't ever been excellent. And there are many ways in which it has become degraded over time. And gamed by middle-income countries that are suffering, but they're not contributing a lot. So I think you're pointing a way towards a reconsideration of what it is in terms of humanitarian assistance and humanitarian relief, and what sorts of partnerships and responsibilities now need to be identified and distributed and reified. And that's hopeful on some level. I do think that the political environment in the United States right now, and I'm speaking a bit personally, but also just widely reading what's going on in this country, is astonishment and fury among people who have been working in areas of poverty and deprivation and misery in this country, but also overseas. And it's very, very good that I hear a robust kickback from the sense that what you're talking about, Saman, but I think we should hold on to that. It's going to be pretty miserable, though. It's going to be pretty miserable. And we have about, by this timer, we have about 30 minutes. Is that correct, in terms of those of you who are keeping time? And I'm not quite sure we do have 30 minutes. I mean, one never knows. So why don't we take a few questions from the audience, and then whoever on the panel wants to respond to it, or you can direct your question to one of our 3 outspoken experts. And we'll do this very quickly, okay? It won't be for everybody, but just, a few questions from the audience. Yes, sir.
So this is from the online query of 2000.
Would you tell everybody how many people are online?
Yes, I believe there are close to 2,000 people watching online. We have some questions coming in. The first is, given the recent funding cuts to health and humanitarian aid, it feels like we're facing a historic opportunity to rethink and reform global and humanitarian health. What do you think, and what do you see as the next tangible step to move this transformation forward?
Well, that's an excellent question. Saman, you were talking about it to some extent. Yeah. I'd like first to hear Petra's perspective, and we could brief one, because it's a very rich and comprehensive question, so thank you. You know this international order, and you historically spoke about how it has arisen, and the ICRC has also risen and fallen and been in sad shape in World War II, and come back. It's very early, but what do you think might be the evolution of those 2 major international humanitarian agencies, ICRC and IFRC, but also in their role as leaders of how truth gets told, how people are protected, how realism dominates idealism, but the idealism is always there?
I wish I had a magic bullet answer. It's not. So this conversation has been happening at Geneva level. All the peer organizations were all thinking the same. I think the first few months when all of this happened, or the first few weeks, everybody was in complete denial, and we all thought that we're gonna resist and change. Everybody now came to the reality that we have to do things differently. 2 years ago, talking about ICRC, also ICRC went into a financial crisis. They had a deficit of 800 million on their budget, and they had to go through a complete reform, and they did. So one of the key drivers of the reform is go back to your mandate. I think all of the international agencies and organizations, we have to look inward, the first thing we have to do, and go back to our mandates. We've all overflown to fill voids and vacancies and come in and do things that were not at the core of our mandate because no one was doing them, so we picked up the work. And so it was a caravan of 2, it became a caravan of 100 because along the way, ministries of health or governments were not doing what needs to be done. And so we ended up picking up as humanitarians the work of others. I think what Salman mentioned about ministers of health trying to figure out new ways of supporting their health agenda or their national health plans. What I have seen, and this is prior to the recent days, the reason why we operate the way we operate is because the funding and the way the funding comes is very vertical. If we want to reform anything, we have to move from the vertical funding. And what I mean by vertical funding, PEPFAR, HIV. We do nothing but HIV because that's what PEPFAR does. PMI does only malaria, so we only do malaria because that's what funding does. That's what we have to do there. Polio eradication. So we're only going to go immunize zero-dose kids on polio because the funding says polio. We're not going to do anything else. So we're going to show up in this remote village that kids have not seen a healthcare worker possibly for 10 years. Because that's when we go, we find kids with zero dose, 10 years old, so they have not seen a healthcare worker for 10 years. And we're only going to give them 2 drops of polio because that's what the donor said. The funding says this. As a grassroots organization, we face major challenges with this narrative. It's an ongoing pushback from my side to donors to say, we cannot do this. These are operations that are highly costly to set up in regions that are extremely dangerous, remote. There are no setup there. We cannot show up. I mean, most of you here are healthcare workers. I mean, if you show up in a village that they have not seen a healthcare worker, you would imagine the questions you're going to get. And from everyone, from the mother, the father, the grandpa, the grandma. I mean, everybody is going to rush to that one healthcare worker that most of the time goes on a bike with the vaccines and their backpack and shows up, has nothing else to provide as health services. So one of the reform looking ahead is going a bit horizontal. Let's do integrated health services. The funding is scarce. We can do more for the same value. We can go to those remote areas, give the polio drop, and do something a bit different, like something else, provide mental health, psychosocial support, primary health care, give other services which are not as costly if we want to do it on another round. There's one of the countries where we do health programming. I was talking to the health director, and she said, on Monday, we distribute bed nets for malaria. So the van goes, gives bed nets, comes back. On Tuesday, we take our polio vaccines and we go again. We give the vaccines and we come back. On Wednesday, we go to do first aid training because the funding is on first aid for Wednesday. And so I have the same healthcare worker and you're getting paid from here, and then here, and then here. This is for us all also to push back and ask donors. And I was in DC earlier this week, and the discussion at the Hill is also pretty much similar. We have to do integrated health services. Again, don't quote me. I mean, they're not sure how, but yes, but they're looking, but they're looking on doing things a bit differently, and possibly because of the less funding, there is an opportunity now of doing things differently. One, inward looking, going back to our mandates as international organizations. Second, outward looking and discussing solutions such as pushing back on the prize. It's sexy and flashy to say we eradicated polio. We're not going to eradicate diabetes. So that one, primary healthcare is not as flashy. So we keep funding polio because there's a cup, there's a prize at the end of the road. There's no prize for diabetes. Thank you.
So you have your time to respond. And then I thought there's a question over there. The question that was asked from the remote audience was pretty rich. So first of all.
Oh, me?
Yeah.
Okay, I'm seeing here.
Well, 22 minutes.
Want to speak. Okay, yeah. Actually, reform is really an interesting word.
I don't think you're projecting.
But,
is it? It's working? Okay.
Oh, it's working, eh?
Now it's working, yeah.
Okay, I agree, actually, and it's really, really an interesting issue here. It is brought on the reforms. I think a right word here is aggressive reforms, because the world had been already initiated the reforms in a long time, even in humanitarian crisis. I'm sure you all clearly have a recollection on the humanitarian reform. I think it happened in 2005, in which we created cluster approach, okay? And actually, an outcome, we had a number of clusters, around 11 clusters, I think. And we added intercluster coordination platform, and we created OCHA. Okay. In 2006 in Istanbul, we had International Humanitarian Conference, in which we added another platform of humanitarian development and peace nexus. Actually, it grows also on its own as a platform. We also had a grand bargain commitments as well, in which we emphasize actually the cash programming, etc. As a result, we had reforms already happen over years. The issue is we didn't have a right speed. Here now is an opportunity of increasing to become aggressive more actually on our reform. Actually, on the donors also, I think it was in 2006 we had the Paris actually declaration of the donors, in which we created SWAP's approach, in which the principles of SWAP, it was actually creating the basket funding, and actually all the donors have the money in health in one basket. And I remember at that time we were told that at the time you are creating a swap, actually in your country, a principle it was actually create in every area a ceiling. And if, for instance, health has reached a specific ceiling, it is okay to have the money to be directed to other areas of work. So we had a lot of our donors refuse. They say, no. Our mandate is only health. How are you taking the money, example, in agriculture? Okay? The result, what I'm trying to say here is we had the reforms, and actually we have to restart and to relook where we stopped. And actually accelerate our speed. And I really like integrated approach, okay? I'm sure all of you remember Swed Al-Matar Declaration on primary health care here.
Maybe not all the people.
And after Al-Matar Declaration of primary health care, we had Astana Declaration of primary health care. It's all on the reform, trying to emphasize the principles of the primary health care. And one of the key issues, it was an integrated delivery of service. It didn't happen. Okay. Our problem is us. We have to relook where we started in terms of reforms, and actually how are we able to actually increase or accelerate our speed of.
Well, I mean, what you're describing, with deep bureaucratic knowledge and also clinical knowledge, the two of you, is sort of a crisis of the humanitarian community and how it has become so complex, so rooted in rivalries, so driven by the egos of donors, that it is essentially impossible to be efficient at the field level. And that was a major concern of the Alma-Ata Declaration. It was primary care for all at the grassroots level, although I'm not sure they used the word grassroots. But it was essentially, let's clean this up and get efficient and realize that our major concern is who is living in misery. And there are a lot of people who are living in misery. So it was a wonderful question. I think you both have given wonderful answers. And sir, you in the back, you've been most patient. Could you ask your question? And I'm going to warn Salman that he's going to be the first to answer it. You need to get to a microphone. Yeah, thank you. And if you could just introduce yourself briefly.
Can you guys hear me?
Yeah.
Okay. Hey, everybody. Thanks for coming. My name is Eli. I'm a pediatric resident at Boston Children's. I'm also an investigative journalist. I have 1.5 questions. My half question is a follow-up to what we were just discussing. I was just having a conversation with Hamid Jafari, who a lot of the people in this room may know this morning, one of the things we were talking about is not only is there this problem of efficiency of delivery of services if you only do polio on Tuesday mornings, but also this problem of distrust. And so I'm curious, in an increasingly fragmented world of global health delivery, including a world where some organizations may not survive and others may survive, how do you combat the burgeoning issue of distrust, not only sort of this theoretical soft power, but literally people may not, if they don't believe that we're there for the right reasons?
Sir, that's 100% question. That's not half a question. Could we grapple with that? Let's do a little triage here. Is that okay? That's a huge set of issues.
Absolutely.
Okay, thank you. All right, Salman, you're on first for that. Again, briefly, because we do need to, have some sort of sonorous closure.
Well, so I want to say a lot about that because I think there's a lot of distrust. And, over the years, we've had a lot of international organizations working with very little accountability. And I just know from our own work in tuberculosis, the United States had a policy of how to treat TB in 1962. Developed in 1957, made international policy in 1962, and that was to find people with TB using X-rays, give them the proper drugs, and give them preventive therapy. Just really simple stuff. Difficult to do because you need health systems, but simple stuff. And it wasn't actually made into WHO policy for countries until March 4th, 2018. 2018, from 1962. And so countries were told to do less than that for various reasons, linked to they'll get confused, they don't have the capacity, et cetera, et cetera. And I know that in other disease areas, there have been similar things happening. And I guess, if I were sitting in the countries and I were told to build a system that didn't actually meet the needs, and then suddenly people are like, oh, you need to do integrated care, I think that would be difficult to just absorb suddenly. Again, I'm going to just jump back to the Philippines because it's been on my mind recently. They've got some major health problems, one of which is TB, one of which is diabetes, one of which is maternal death, one of which is infant mortality, right? And it's, as you say, if you go to a village and you just do, like say you screen somebody for TB, but you don't check if they're pregnant or, do whatever else, to screen for diabetes, it would be insane because you're rolling out this entire operation. And that's precisely what people propose should happen, not integrate, because that's the way the ministries are set up. And the ministries are set up that way because the WHO is set up that way. And so it's just this whole cascade. And so I think that there has been distrust. And I know that because I know that every time I've gone to a place and talked about the simple search, treat, prevent things, I ask the people that I've spoken to, so what do you think? And one of the things people sometimes say is, we're really angry because we were never told that it involves this. And so I think there's that element that we have to be mindful of. The other thing, I just think as citizens in a I guess a democracy, we need to be thinking that, when you think about outflows of capital from Africa and aid dollars going in, the outflows go to the private sector and the aid dollars come from the public sector. And we've been actually underwriting that flow for decades, probably centuries. And so we have to be starting to look at what is happening from the public purse. There's a lot of nostalgia about USAID. Anybody in this room that's worked with USAID knows that there are deep flaws. There are deep challenges. So those of us that want to rise up and say, put it back, should be saying, put it back, but let's fix some of the things that weren't working out. The WHO, same thing. I don't think one should pull out from these organizations or destroy them. But I think we definitely need to be thinking, how do you rebuild trust in the communities? And then the last thing I just want to make is a broader thing about healthcare, the healthcare agenda. Hospitals are critical, right? People need them. If you need a heart transplant or you need surgery, if you have your appendix burst, you got to have a hospital. But more and more people in the 21st century, we're finding that more and more there's diseases that kill people that need to be diagnosed and treated in the communities where they live and work. It could be high blood pressure to prevent strokes and death from heart attacks. It could be diabetes, et cetera. TB. HIV, Hep C, mental illness, you go down the line. Those are not the systems that we're building. We're building these vertical programs, yes, and we're building large hospitals that become profit centers that are built on the United States model, which has not shown itself to be highly successful.
Get to the issue of trust here.
So I think we'd have to actually, sorry to talk around your point, we'd have to basically get back to saying, what is the focus of this work? It's to improve people's health outcomes, to improve their opportunity sets, their capability sets, right? That's the purpose of this work. And I think we've kind of lost our eye along the way that these are just these aid programs. The argument that these aid programs were not extensions of countries' foreign policies is utterly ridiculous. They've always been extensions of countries' foreign policies, and that's why they probably haven't worked very well. So I think we need to say, what is the outcome that we seek, and how can we best use this money? And maybe the outcome is we don't really want to help people, we just want to have boots on the ground so we can control ministries of health. That would be an outcome, it would be an honest outcome. But if the outcome is to actually give care, prevent death, preserve the sanctity of life, then we have to think about how we're going to orient that.
So, there's an old and hackneyed little phrase, every crisis brings an opportunity. That's too small a phrase for the debacle we're facing. But I do think, and the speakers here have very frankly spoken about their distress, what is in the process of being destroyed, how difficult it is going to be to return to something that is integrated and sane and merciful and strength-giving, capacity building. It's not as if the system that has been destroyed by some sort of auto pen in the White House is the only system that we're capable of. And I do believe that we have an opportunity, and some of you on this panel are more certain we have an opportunity than others. I mean, I can feel there's a different tension of dismay and, what's next. And that's completely human, and also it's bureaucratically plausible, depending upon where you sit, what you can envision. So from a university and NGO, our man in the middle here is, fired up and ready to go. And the two flanking him are, deeply embedded in international organizations that are wonderful but cumbersome. And so there is and cumbersome with all the edges that any of us who've done field work or have met them in the field understand. This is, the sort of the French word, this is a bouleversement. You have to tumble and roll over and then stand up and get your head clear. It's a impossible position to put the world in. It's a really incredibly irresponsible set of actions that have forced this, and not just on the United States, but as we know, on the world. Not that the reach of the United States is so vast, and you can hear there is a lot of criticism from the three seasoned panelists. There could be many criticisms they make about how governments and other organizations work elsewhere in the world. So this is a time of crisis for sure, and I can already hear from this group and from the audience glimmers of opportunity. But I don't want to end on a high note, actually. Because this is a desperate time in terms of humanitarian response. Because remember, humanitarian, these are people who are the clients of agencies and universities and healthcare workers and scholars. People in real need are going to have a much harder time for a while. And so if we could close, because the question from the floor or from the listeners is going to take quite a long time to answer, all right? So I know you have many good questions from our wonderful audience, and there's many good questions here from this audience. But I would like to, each of you, in closing, because we have about 6 minutes, huh? So max 2 minutes, and then we might get to where we need to be. What do you think you're going to do in the next 6 weeks to try to make sense of this? I know that's an impossible question, but I know that you also, you know, you're busy, skilled leaders, and so you have to have a sense of what you're going to do. And Petra, could we start with you? Because you're pretty precise, and you don't talk too much.
Okay. I think from our side, we're definitely going to have to do better choices. And what I mean by better choices, we have to come up with solutions. We're going to have to stop talking about the problem. We all know the problem, and it's been very well chewed and time up to swallow and find a solution. Our focus is really going to be co-create solutions, advocate in capitals where what are the things that can work and see if we can influence. I mean, it was mentioned here, but it is no secret that foreign aid has to match politics. And so there is a change in politics, and we have to read this change in politics and how the geopolitics is changing and figure out how the humanitarian aid solution comes in the midst of this and try to shape it in the best way possible. We do have ideas, and the vertical one is one of them. The integrated health services is another one. Localization is the third one. We talk about it, all of us. I don't think we have a right definition. Each one of us has a different definition of localization. For us, localization is strengthening the local people and their systems. For others, localization is hiring national staff. They look at it as localization, and then when they leave, the national staff become jobless, so they have not strengthened the system. So these are just things to think about, but those are the things we will be advocating in the next few weeks.
So I'm told we have a little more time.
Okay.
Yeah, so we've got, what, 5 more minutes? 10. Okay, so you are succinct, and you've set the stage beautifully for how you're going to work in the organization. And what strikes me is that there's a we here. You know who you are. I mean, it's good that after 160 years or how many years you're going to claim that your organization still knows who it is, and that's a triumph. And so you're already figuring out who is going to do what and how you're going to think about this. You're not talking too much about how you're going to lead or participate or work in a group to rewrite the sort of structure of NATO, but you're speaking essentially about the international Red Cross and Red Crescent movements, right? Mm-hmm. And yes. I think that's the sort of discipline that we would hope and expect would come from you and your colleagues at ICRC.
I mean, I think as a membership organization, when we work, and particularly during these difficult times, we leverage our grassroots. So American Red Cross here in the U.S. is supporting us with the U.S. legislations to help us shape up some of the international policies. The German Red Cross with the German government. So we're activating our network to influence as we come along in this journey. We are doing an internal relook as we speak. The organization is going into a massive survey of how do we want to operate in the next 100 years and how we're going to do things. Again, going back to mandates. Yes, we're going to have to walk away from things that, unfortunately, we're not going to be able to do them, and others have to either do them. Governments, they have to assume their responsibilities. working as a charity for all might not be the way forward during this time.
So I'm going to turn, thank you. I'm going to turn, Saman, you're going to be last because you're not quite in the nested UN or Red Cross movement structure, right? You're more of a free agent. So, Dick, will you talk about, from your perspective, WHO, but also WHO as it links up with virtually everybody else? What do you think you would want your outfit to do, or what are you trying to make happen? From where you stand, what are the steps you're going to take?
Yes, actually in a WHO, we view it actually in the two areas. As you all understand, the WHO is a member state organization. Therefore, we are only acting as a secretariat, actually, of our governments. So we have area in which it is priority about the WHO itself as an agency. And we have another area is how are we able supporting our member states to navigate what we are now. Therefore, in the WHO, as we've already started it, action one is to reprioritize, to clearly try to look inwards, as we've said, to clearly understand what are our core mandates and what are the priority issues in which we are having now. And on the last part is to really try to understand who are our strategic partners at the moment. Actually, health is really interdisciplinary area of work now. Our 2/3 of high-threat pathogens are from animals. As a result, we have to see how are we able actually collaborating with other agencies actually in the world. Therefore, it's clear priority to reprioritize, and at the time we reprioritize our activities, we will also restructure our organization, actually in one way or another, and two, to understand what are our strategic partnership. The last one is resource mobilization. We have to find actually other sources of resources in order to actually implement our activities.
Could I interrupt there? Because you are a unit that coordinates on certain parameters nation states,
Yep.
You will be looking for more funding from the nation states.
Exactly.
Correct?
Yeah.
'Cause that's a big deal.
It's really tricky at the moment, as we've already talked here. In the past, everyone was talking, actually, if we don't have the US, we'll have EU. And we've realized it doesn't happen like that now. As a result now, we have already started talking to our member states themselves. Therefore, WHO have created now investment rounds in the countries, and in Africa last year we had our investment round in the Regional Committee of Africa, in which all our ministers of health are coming, and we had our pledges closer to around $50 million. Actually, it's a pledge. It isn't hard cash anyway, and it is actually one of our approach in terms of resources. At what our member state, I think the critical issue now, particularly in Africa, is to increase awareness of the impact of the USA in this issue we're talking about here now, okay? Actually in health. As you know, we have African Union in Africa, in which almost 15 years ago it declared Abuja Declaration. Mm-hmm. And under Abuja Declaration, the member states were actually required to actually increase allocation on health to around the 15% of their budgets. I think until the end of the last year, only 2 countries have reached that, okay? The result is to increase awareness and actually to increase the commitments. How do we do that? I think WHO, after we already started to actually, to bring the parliamentarians now actually in the picture. because we view the parliamentarians and parliamentarians are the people representative, are creating laws, approving budgets, and are also are holding accountable to the governments. The result is an interesting stakeholder to bring actually on board in this time of crisis. Over.
So, Salman, you've been very patient. I would invite you to speak from your perspective, but in the context of what our two leaders from very esteemed international organizations have both said, which is figure out priorities, figure out strategies, figure out ways where you, the Red Cross movements and WHO can function well and improve analysis and delivery, and there are many steps for doing that. Where you sit, if you can define that, because you have many roles, but Partners in Health, NGOs, academia, I'm giving you a broad tablet here, but so I do want you to be precise. So as I'm speaking to you, think about what you're going to say, because you have you have some time now. I mean, we've got maybe 2 minutes, and I may say something brief at the end, but you're sort of our closing batter here.
Well, I'm glad you didn't want to end on a positive note, because I do think that a lot of people are going to die from the changes. They've been very abrupt. They've shocked the system, and even if one has issues with the way the system was organized, it was organized in a certain way that could deliver care, and I think that is the crisis that we face. And organizations like the WHO, like IFRC, ICRC, I think are critical. Any of the situations we're looking at, we could be looking at Sudan or Gaza or Ukraine or Mozambique or wherever. Even if there's not a war necessarily, you see that the WHO are critical partners, and you see that the Red Cross is a critical partner. And I think what I'm seeing more on the ground is that this opportunity, people are going to lose lives, but there's this opportunity for countries to take a little bit of ownership. And by countries, I don't mean the governments necessarily, because I think one of the things that we've seen is local NGOs are there. And so I wonder if part of the realignment that maybe helps with the cost, but also takes away a little bit of the coloniality that's kind of been imbued in this whole thing for the last few generations, could local partners really take the lead on some of the things with external funding? And I think we've heard that we do need to continue funding from governments, but maybe it needs to be done in a slightly different way. Development Inc. maybe needs to change a little bit, and it has to be, affected differently. We've tried to do that at Partners in Health. It's partners on the ground that are running most of the things, and I think that there's been kind of like a pullback from having outside people always going in and rather having more people on the ground. I'm seeing that now, as I keep mentioning the Philippines to you because it's on my mind, but I'm seeing that there too. There's local NGOs that are like, oh yeah, we can get money for this or that. It's not big money. It's not $50 million or it's $100 million, but it's something to keep the work going. So, I think we should have despair that lives will be lost, but also we should try to work and get some of these other avenues functioning well. And maybe if funding from Western countries increases again over in the upcoming years, it will complement that. The other thing I think I've heard both of my colleagues say, and I think it's so important, is we have to be talking to legislators and educating them, because I think there's a lot of. I was talking to one of the U.S. Congress people a couple of weeks ago, 3 weeks ago, and their team was not aware of that TB was airborne and such a dire problem for the U.S. and cost the U.S. economy like it's between $7 and $11 billion a year, and that we have 750 military bases, and et cetera, et cetera. So even if one looks at one's own self-interest, there are reasons to be acting externally. And we could be talking about Zika coming into Texas. We could be talking about Lyme disease moving to the northern parts of the country. You still need to be thinking about these things, right? So I think that that's the other angle where we are really going and educating people. So it's a dismal moment. There are these glimmers of hope, and we really have to try to think of how we're going to rebuild the system as we're moving.
Thank you.
Easier said than done.
Well,
easy to say from an NGO and academic perspective, but I think it is doable.
Thank you. So I'm going to close now, okay? Even if we might have another 2 or 3 raggedy minutes. I mean, from my perspective, the 3 of you have been really remarkable interpreters of the dimensions of this crisis and great interlocutors for your constituencies, your outfits, and have a sense that there's running room, that universities, students, young professionals, I'm sort of scanning the audience, this is a time for initiative and also solidarity. And it's a time for people to start talking to people in the dining halls or in the restaurants or in your wider friendship circle about a certain aspect of mobilization. We're going to need you all. Truly, we're going to need you all. Because there's going to be more misery. And that's unmistakably a problem in the United States, where there's already vast latent misery that we have not addressed. But it's true throughout the world. So it is a challenging time. It's a time where it's going to be harder to get money from various sources that we have thought we could get money from. But it is a time for speaking to each other about how tough it is and what you still want to do. And don't give up on what you still want to do. You're just going to need allies and confidence and a perhaps slower and more articulate sense of advancement. It may take you longer to do things. You may have to do lateral, sideways work. You may have to do something else for a while. I'm thinking of how you're trying to pay for graduate school or you're trying to get through certain training periods. There's going to be less, from the United States perspective, less government and state largesse. And for those of you who are from elsewhere in the world, you can tell from our speakers, there's definitely going to be less money for them. So that means it's on your initiative. It's on your sense of bounce back. It's on your sense of not giving up. I mean, there needs to be a bit of a campaign mode here, so that this very strange government, I'm putting government in quotes, it's hardly a government, this very strange regime doesn't crush aspiration and doesn't consign larger numbers of people to misery. I'm scanning the room. It's such an impressive group of people. And I have a sense of solidarity with the 2,000 that you're monitoring. This is the sort of thing that you see in wars sometimes. People do everything differently because they have to. This is a different kind of crisis, but we need to have all of you in a more congenial and collaborative mode, and helping each other and having your teachers help you as you help your teachers. And that's not just medicine, that's everything. Not just healthcare, that's everything. We've got to do this together. I must say, I came into this conference yesterday. I mean, looking at this conference, came to town yesterday, and had this sense of, what are we going to say? And look at you, the three of you. You've created a great set of insights and observations and modeled resilience. I'm very grateful to the three of you for this, and grateful to those of you who have come here, and to those of you who are on the long, busy distance call. And I thank the organizers for being so adept at accommodating to the numbers and the changing issues, because these things begin with one thought in mind, and then, of course, there's reality intrudes. So thank you to everybody, and I personally feel that this has been an excellent session, and I will turn it over to whoever is now going to take charge. So thank you.
Thank you, Jennifer, Petra, Dick, and Salman, for sharing your expertise with us today. It was a real masterclass. I personally learned a lot, and I'm sure and I'm confident our audience has as well. For those of us who are here in the room, we have a break until 11:30. We will resume our streaming shortly at 11:30. So for those of us who are online, please be back with us then. Thank you so much. Refreshments are served in the room to the right, and we'll see you at 11:30. Thank you.
Serve my needs. I'm not going to do whatever in your country you can do, vote them out or whatever. That alignment is where we need to go on the other end of this. And it would have been easily, nicely, you can do it later today. That, I really thought, I thought they basically said that. These are missing. What about the for delivery? Are we helping out or delivering? Focus doctors or nurses, one clinic, referring to one hospital, is not a solution to the problem you're trying to address. And, after 30 years of doing that over and over again, I still go back to the real entity that we need to strengthen is the government's ability to deliver a delivery system for the diseases that their population is born with. It's not rocket science, but it's complicated, and you need to persist. It's not a 3-year solution, it's a 20-year.
We have time. So take this way so that I'm going. And then when we look at some of that, it will be better if we did something really great. Yeah. Since I'm going to be sitting over here, might as well. Oh, that's great. Well, then we will get that. I'm going over now.
This is my warning for 2 minutes. In 2 minutes, we're going to get started. So please grab your last coffee, your tea. Okay, now we're at time. Please take your seats. Thank you so much for those who are taking their seats. Make yourselves comfortable again. It's a wonderful morning in Cambridge for those who are joining us online. We're going to get started with our second panel of the day. I'll just give the people in the room 1 extra minute to find their seats.
Oh, now I can see you.
Well, welcome back. Please allow me to introduce our next session entitled Impact and Influence, Examining the U.S. Role in Global Health. Giving opening remarks for this session is Marcela Alzan, Angelopoulos Professor of Public Policy at the Harvard Kennedy School and Director of the Health Inequality Lab at the same school. Dr. Alzan, I will now let you take it over. Thank you so much.
Thank you so much to the organizers for having me and for putting together this fantastic session. My name is Marcela Alzan. I'm the Angelopoulos Professor of Public Policy and the Director of the Health Inequality Lab. I'm a physician economist, and I study the causes and consequences of health inequality in the U.S. and abroad using a combination of natural experiments and randomized trials. Today's session tackles the question, what happens when the U.S. has a reduced presence in global health? The U.S. has long been at the forefront of global health, driving impactful initiatives that have improved health outcomes worldwide. The U.S. has actively worked to prevent, detect, and respond to disease threats globally. It's worth remembering why the U.S. does this. American commitment to global health wasn't driven by humanitarian instincts, those matter deeply, alone, but also by economic and national security rationales. The WHO's Commission on Macroeconomics and Health, chaired by economists like Jeffrey Sachs and aided by another one named David Bloom, helped shape the economic case for global investments that led to the great creation of the Global Fund to fight AIDS, TB, and malaria, and PEPFAR, the President's Emergency Plan for AIDS Relief. These weren't just acts of charity. They were smart, strategic investments. At the same time, there's been tension in how we justify these commitments. Some argue global health shouldn't need an economic rationale at all. Health equity is a moral imperative. Certain disparities are so unjust that they demand intercession no matter what the cost-benefit calculus says. But isn't it a powerful thing when morality and pragmatism align? When the just thing to do is also the smart thing to do? And so the question for this session is, what happens when those investments are pulled back? What happens when the U.S. retreats from that intersection of justice and economic and geopolitical strategy. From PEPFAR to PMI to USAID, the U.S. has made significant progress despite these challenges that were mentioned. PEPFAR invested over $100 billion in combating AIDS, saving more than 25 million lives, preventing millions of new infections. USAID has further reinforced these efforts by reducing child and maternal mortality, increasing vaccine access, and strengthening health systems in over 80 countries. Since this new administration, USAID and PEPFAR have experienced significant operational disruptions. An executive order mandated a 90-day freeze on American foreign aid to assess, quote, pragmatic efficiencies. And as we mentioned last session, alignment with the new U.S. overall foreign policy. Secretary of State Mark Rubio announced last month the termination of approximately 83% of USAID contracts, effectively dismantling that agency's capacity to deliver foreign aid, and has announced preliminary plans to put the small remaining parts under the auspices of the State Department. This abruptly stopped numerous programs affecting tens of millions of patients worldwide. In this plenary, our esteemed panelists will discuss the U.S.'s historical contributions to global health, examine the significance of its funding, leadership, and participation, and they will ask answer what this American retreat means for the health and security of those living abroad and citizens of the United States. Now let me introduce each of the speakers. We have Lois Pace, former Assistant Secretary for Global Affairs from the U.S. Department of Health and Human Services and Advisory Board Member of the Biden-Harris COVID-19. Eric Gooseby, Professor of Medicine and Director of Global Health Delivery and Diplomacy from the Institute for Global Health Sciences at UCSF. Welcome. Sheila Tlau, Co-Chair of the Global HIV Prevention Coalition, Special Ambassador of the African Leaders Malaria Alliance, Champion of Nursing Now Challenge, Chancellor of Botswana Open University, and member of Pontifical Academy for Life. Welcome. And moderated by Yuli Norheim, the Mary B. Solenstall Professor of Ethics and Population Health at the Harvard T.H. Chan School of Public Health. Thank you so much, and I'll take that.
All right. Thank you very much. This was the perfect introduction to our panel. We had a terrific panel just before this, and we will dig deeper into some of these issues. But remember that the first panel was on humanitarian aid. We'll focus now more about health financing and health systems. And I have to start by saying that I'm a Norwegian, and Norway is still committed to 0.7% of GDP to ODA. I was born in Ethiopia, and I was raised in Ethiopia, and now I live in Boston. So I want to express this deep feeling I have about the norm that I have always been led by, the ethical norm of global solidarity. So what has happened is, of course, devastating for all of us. But we will try to think about this and think about this clearly, and we have a fantastic panel that are quite diverse, so we will have different perspectives on these issues. So I want to start by going back before January 2025, and let's talk about first the contribution of US to global health. We know that investing in health has huge impacts. So I want to start with you, Sheila. Can you talk about your reflections, your experiences from your perspective?
All right. Thank you very much. And good morning to everybody. I had a 24-hour flight coming here yesterday. So if I renege, just know that it's the jet lag speaking. But I promise you, I will wake you up. Yeah. I'm up already. Yeah. So I want to thank the invitation by this great university. It's not my first time here, and also to welcome those who are online. I know in there is civil society. I was born and bred in civil society, so I love you guys. And I asked 3 former ministers who were ministers with me when I was Minister of Health of Botswana to go on in, because when we are talking influence and impact, it's really us. Yeah, but I'm going to be showing you, giving you a little historical perspective, because sometimes we say the US has done a lot. Oh, so maybe 20 billion this. Okay, I am it. I am standing here before you as a former Minister of Health, but really a product of the US influence on health from the Peace Corps volunteers of the 60s. I was educated by the Peace Corps and all that, and my undergraduate degree in New Orleans was by USAID in collaboration with my government. Graduate, in fact, even the PhD, I got my scholarship from the W.K. Kellogg Foundation, American, right? Right. So I'm standing before you, a nurse, one of the first nurses to be made Minister of Health in the world, not just, but it was because of that grounding by the US collaborating with our countries in social development, in governance, in everything. We have not mentioned a lot on governance. So for me, the elephant in the room is going to be exactly that, governance. But I'm not going to take a long time, because he wants us, he's saying we should do just 5 minutes. And
he said 2 or 3.
He said 2. No, we agreed on 5, because I told him I've been 40 years in the AIDS response. I started in 1985. This is a whole lot of history. I need to write a book. So anyway, okay, so that you have that has been that influence. And through the Mehari Medical Project, actually USAID was able to train a lot of nurses from Botswana. And I'm not talking just Botswana, it's really Botswana, Lesotho, Eswatini, and Namibia. We were able to train quite a lot of nurses who became a formidable force in primary health care. But what were the other ingredients in a lot of these countries that made that primary healthcare system work before HIV? It was good governance, zero tolerance for corruption, peace, and indeed community participation. So by the time primary healthcare came, we already had good healthcare systems in place until the AIDS epidemic came. Now, I happen to be a minister who came in immediately after AIDS was on, and it was really wreaking havoc in the country. The great part being, because of the good governance, already, I need some water, my government was putting in money into health.
Thank you.
Thank you very much. Now, in 2001, it's already been said by my colleague here, our leaders have said they were going to devote 15% of the budgets to HIV. And it just so happened that Botswana at that time was, I think, on 12% or something like that. But then I was called by our president. I had been civil society wreaking havoc, and they saying the government should do this. I think it was more to shut me up, and I was made Minister of Health to say, let's see what she can do. But when the president said, I would like you to come and help me, I said, only if you put 15% of the budget to health. So now that's advocacy, underline it. So he said, I'm giving you 20%, but I want a report every 3 months. And guess what the army was being given at that time? 5%. So that you see, there is a reverse sometimes with our leaders. More goes to the army when in fact the enemy is right within the country. Who are you fighting outside? So that we need to also looking at issues of good governance. But anyway, what then happened, of course, was with that 20%, we were able to do a lot. But I already had partners. I'll tell you something. Donors like to jump on the bandwagon of success too. So we had donors, PEPFAR came later,
at that time when I came in, PEPFAR, we had the Global Fund, we had Botswana-Harvard Partnership, I think my colleague Phyllis Kanki is right here. And these were the people who were doing research so that I do evidence-based decision making. And indeed, with that help, guess what happened? We managed within 4 years to bring down the rate of mother-to-child transmission from 29% to 8%. Within that 4 years, we had 80% uptake of the people who needed ARVs. And the government was able to pay for that. So that we also are looking at really domestic funding, which was there at that time. And indeed, also good governance. But those were the successes. And so that I want to thank the United States government, the people of the United States, for having helped us all that way. Granted now, their priorities have changed. But at the same time, we need to say, what is it that we learned and how do we spring forth? Now, with my 3 minutes, let me tell you how I think we can go forward. And I have just 3 things I want to say. First is to just say fair access to healthcare is a political choice. So it is therefore on our leaders. Right now, as the chair, as the special ambassador for the African Leaders Malaria Alliance, with my background of advocacy, I'm actually advocating with the African Union to ensure that we have domestic financing in every country. And indeed, for malaria, a lot of our countries are forming end malaria councils where the private sector is being roped in. Spiritual people, the spiritual leaders are being roped in. Yes, by the way, I do advise the Pope, and I make sure that all those archbishops become part and parcel of this so that they can preach malaria elimination in church. And indeed, we have young people to ensure the sustainability of the malaria response and also the HIV. Secondly, I want to say that health is made in the homes. Hospitals are for repairs. And indeed, my colleague has already said so. We are emphasizing that backwardness to say, let's go back to primary health care. Let's go back to where nurses were well-trained, well-remunerated, and working with community healthcare workers to ensure that the people at community level have access. That's one thing we still can do as Africans and all that. And the last thing is to really say, well, global health equity is for the future of humanity. In the ultimate, we are branches of the same trees and leaves of the same branches. No country is safe until all countries are safe. So that we need that global solidarity and shared responsibility to continue. But we have to put in our bit so that we continue as partners, not as recipients of our arms. So that to me it's really that. And the final thing is to say we need more leaders who are female in the healthcare industry. My belief is that when she leads, a lot of things happen. I am that example. And so I want to encourage everyone who is here, who is female, to say, if ever you had any inkling on taking a political office, please do so now before it's too late, because otherwise, without your participation, we will not have gendered health policies that can be transferred across the world. So with that, thank you.
Thank you very much. I should have given you more minutes. Moving on to you, Lois. You worked for the Biden administration in the Office of Global Affairs. What's your perspective? What was your contribution?
First off, let me say that it's very unfair to make me go after the Honorable Minister, but I'll try to do it. Hopefully you guys can hear me. And I can be brief because she told the story better than I could have. But the reality is the U.S. was really about making big bets. And that was notable. It was groundbreaking for us to show up in the way that we did. And it doesn't just start with PEPFAR, right? I mean, if you take it back to days of smallpox, right? We were about coming together, including with the private sector, but also working through government to eradicate diseases. People weren't talking about eradication in that way. People weren't really going after it. And I have to give credit to the advocacy community, where I was also born, to push us in that direction, right? It's because of Rotary, because of the LGBTQI+ community, because of these advocates, because of the faith-based community, that we placed these big bets, and we stuck with it for the long haul. And that's another notable contribution we made. It wasn't just about the money, it was about the timeline and the fact that we didn't need these answers immediately, right? Now, Ambassador Goosby could talk more about how we did make and measure progress, but the reality is we were willing to stay in it because we knew what it required. Importantly, those bets were also leveraged to bring in other actors, and that was huge, right? And when the previous panel talked a bit about contributions of other countries and sort of the domino effect, but other countries, other companies showed up because the U.S. was in it and because we pulled them into it, right? And so that also is quite notable. The last thing I'll note is the ways that it wasn't just about bilateral funding, the PEPFARs of the world, for example, or the President's Malaria Initiative, but it was about how we did support and leverage that funding for multilateral initiatives, for the World Health Organization, for the Global Fund or Gavi, for other endeavors that were not just about the U.S. being at the table. And so that's all that's lost. It's not just about what's coming from D.C., right? But it's about the conversations they're now having in these other settings, like was said about WHO and PAHO for that matter. Let's not forget the regional offices of WHO. It's about what's being talked about in Geneva or frankly in Addis or elsewhere about how this has this sort of trickle effect to some of these multilateral initiatives, again, at the regional level, including in places like Latin America and Asia. But it's a great story still to tell, and I think we should continue to celebrate the contributions we've made because someone will come along someday and want to hear this story and maybe want to open that book again. So I don't want us to only talk about this in the historical frame. This is still work that we get credit for doing up until today, and I'm assured that with people in this room and online, we will find some way to continue.
Thank you. And Eric, you have worked, you led PEPFAR, you worked on TB. Can you tell us more about that contribution and maybe also what the cuts now mean on the ground?
Sure. It's a pleasure to be here with you today and commiserate around the challenges that are in front of us, and as we better understand them, really position ourselves to respond. I think that it's been a breathtaking display of kind of displacement of expectations and priorities with nothing that really replaced it. The discussion has not occurred. There is no discussion. It is a mandate, and that mandate has kind of been implemented without a concomitant implementation discussion. So it's been a lot of reacting. People keep waiting for the dust to settle so a conversation can occur. And so far that has been prolonged longer than anyone thought that it would or should be. The challenges to the multilateral community are great, but I think the withdrawal of the bilateral program of PEPFAR through the conduits that USAID has created, as well as CDC and other U.S. agencies, those platforms will take weeks to dismantle completely, but have already started to decay. And I think I've been humbled at looking and talking to colleagues in country who are reacting as if a final decision has been made, understandably, but at the same time incorrectly, conceding too much at the beginning of this dialogue has been the mistake. The conceding should have been managed better, but no fault in that there was no clarity in how to do that or kind of historical precedent in how to position yourself with a non-dialogue. So I think we're in a position of finding out, and I think PEPFAR has often been in a position of being a large resource motor that's introduced itself to ministries of health and multilateral programs in a way that has not taken full advantage of capacity expansion. And I think if I asked myself to criticize the decisions that PEPFAR made, the core decision to not go with governments and to try to create parallel systems of care completely understood the urgency and the immediacy of having NGO civil society systems engaged. It should have been both and not one or the other. Where there were both engaged, those expansion of capabilities were able to begin to merge as they found their footing and not move away from each other, but realize that there's more power in a partnership as those resources, divergent as they were, strengthened the portfolio of both the ministry and the NGO. So there was a win-win there that was right in front of us. The decision to not emphasize government and develop delivery systems in the clinics and hospitals of the countries we worked in and not create new clinics and hospitals was, I think, a fundamental flaw that we tried to recover from, but I think really is the core weakness of the relationship in PEPFAR-funded countries, the large PEPFAR-funded countries, and is the core of the distrust that the delivery system, I think, has generated with USG involvement in country, and that it is conditional and is, as our colleagues in the first panel really alluded to, dependent on the convergence of both egos and resources at both a multilateral outside of country level, in the capital of the country, and then at the site level. So there's three areas that allow for a discussion to occur where governance could have been what was discussed, but rarely was.
Yeah.
And I think we created parallel systems of care. Now, what I think is a critical concern of mine is being able to acknowledge the missed opportunity, but at the same time re-engage with our colleagues in country, ministries of health and civil society both, to re-envision a delivery system that understands the diseases that the population is dying from, aligns itself with diagnosis and treatment of those diseases, and builds a bench of capability in the Ministry of Health and the surrounding civil society that continues to give when these resources recede. And we have missed the opportunity to build that in a large way, but we have built it in small, significant ways in every country that PEPFAR and other efforts have been in. And I think it is now an opportunity to realign how we look at accountability throughout the system of allocation decision-making to go against unmet needs defined by the population, what they die from, as the diseases that we need to become good at diagnosing and treating, with all the procurement distribution support that reflects concomitant. And I think we can re-engage with that kind of joint effort building together, but with an alignment of accountability that will inform the governance discussion that Sheila was talking about.
Thank you very much for these reflections and pointing forward, and we'll come back to that. I want to dwell a little bit more on the impact on the ground. In Botswana, what is happening there? I expect that we at Harvard, around in Boston, in US, a lot of our research funding is disappearing, future jobs are disappearing, but the impact might be different. Catastrophic for some, but maybe the reaction is different also. That's at least what my friends in Ethiopia tell me. The reaction is different from the way we feel it here. So I'm curious about you first.
Okay. Let me say that on the ground, if I'm looking at a country such as Botswana, for example, when I was minister, 90% of my budget for HIV, for everything, was from the country itself. So that 10% was from the donors. So that you see, when that then disappears, you don't feel it as much as another country, let's say Rwanda or whatever, or Malawi, that where, only 30% of their budget was theirs, and 70 was from the donors. So it really varies. It varies. And I know in my country, for example, I was able to fund civil society because we're working together. And I was also funding members of parliament so that they keep me accountable. And that kind of funding, when it goes off, because there's a continuation from the government, is not quite as felt as where there was nothing. And that's basically where we kept saying to our leaders, put more money into healthcare. Yeah, some did, but it was not enough. And I'm hoping that this is now a wake-up call. Yeah,
exactly.
Lars,
No, I
you're
want
here.
to. Yeah, I'd be happy to build on that because I agree. It's different everywhere, obviously, but a couple of things the rapid retraction did. First off, it made it harder in places where we were making meaningful progress towards responsible transition. I don't know if we talk enough about how many countries, like Botswana, like South Africa, like plenty of countries in Asia and Latin America had already taken on a lot of what the U.S. was doing, not in the exact way we were doing it, because that was not the right thing to do, right? To just say, okay, we will, implement PEPFAR, for example, exactly the way you all showed up with it. But the reality is, plenty of countries knew they had to take this on because we were having these conversations with them, and they were being pressured by their own communities and citizens to do more. What is happening now, I think, is in these cases where countries weren't quite ready for the transition just yet, especially in this post-COVID economy, global economy, you have this gap, right? Whereby they were maybe going to wind down in the next, say, 5 years. Then it's sort of, okay, we have 5 months to try and figure this out. And so that is problematic because that is not the way we would do this work as implementers and global citizens, but here we are. I think there's also something that, coming back to the minister's point also about sort of like where this is more heavily felt. I work now in a position that has me overseeing Latin America and the Caribbean. And so you think of a country like Haiti, that was completely reliant on U.S. and other funding, but a lot of U.S. funding, even across the Caribbean, because not a lot of people care about that region or are focused in that region. And so I think when you really think about humanitarian context in particular, like Petra was saying, there's a great risk that not only health issues are going to be exacerbated or kind of roaring back, but there's this confluence of factors, on top of the health challenges. There's just broader social and other human development challenges and crises that emerge when there's this sudden retreat, again, not just of the U.S. government, but of everyone. And there's no alternative, right? You can't point to a country and say, well, this is your GDP and, you can get this loan and do this. In some places, you don't even have functioning governments, right? So that is a problem that I don't know how to solve, but I do think, just building on what the last panel was saying, we really have to solve it because I think as we're having conversations with policymakers, it's easy for them to imagine there are options in places where they really aren't. And I think we have to be honest about where there are options and alternatives and specific about not conflating those circumstances with places where that doesn't exist.
So Eric, thank you for that. And Eric, I want to ask you, moving to the last part of our discussion, what now? What next? And I want to phrase it as, what kind of advice now with dwindling global solidarity, what advice you started to reflect on that, but what kind of advice would you give to regional authorities, to countries, to governments in terms of health financing, resource mobilization, strengthening the health system, setting priorities? Concretely, what kind of priorities would you recommend?
Yes. I think going back to your population and understanding what, as I said before, they're dying from becomes the central motor of focus for a delivery system. And that should be what is continuously put in front of the system in the way the surveillance information is filtered, analyzed, and deposited back so corrective action can be taken in as close to real time as you can create. To not do that in the government system that has been committed on by the Ministry of Health, the legislature, and the political system, and hopefully the population, that this is indeed what we want as a delivery system. If you match that with these are the diseases we are dying from, you, government, now have a responsibility to align your allocation decisions with those unmet needs as defined by the diseases that our population suffers from, both morbidity and mortality. that kind of concrete, common sense approach to the development, strengthening of delivery system has to have a concomitant line of accountability that allows the political leadership making those allocation decisions to be accountable to the outcomes they create. That feedback loop is never built in the system. Botswana understood that under your leadership early on, and when you talk about owning the budget, that's what it gave you the ability to be creative with. When you remove that from the people in front of the population that's holding them accountable, you dilute accountability so much so that the needs and aspirations and attributions that the donor wants dominate every time. And that is indeed how the money flows into the country. That's how the minister and the president have to talk about it if they want it to continue. When you bring private sector foundation money into it, the same confounder occurs. And we abandon the delivery system that remains in place without that accountability or with the kind of line of lines of governance that explain how they work to the population. So all those kind of arrows that go in both directions are really where I believe we need to go. But I think that we have taken a tragic step off the track that created a derailment of resources that were heading toward a destination of drop in morbidity and mortality. We've missed that opportunity with the chaos and really the destruction of those systems, and the disregard for the residual aftermath of it has been stunning. But I think it is populations like this that need to understand the moment, and governments need to be re-engaged and held accountable many times for the first time for the populations that they're already responsible for, and we need to realign how we hold them accountable and define what their charge is in each given year. And I think a return to that kind of basic understanding of movement, to understand where that resource motor is, I think can increase the number of people under the treatment curve. It's not the solution. It's not enough resources to do what's needed, but we need to really desperately look in each country one at a time at the population and how they are or not aligned with the diseases that they have in front of them and converge those resources. But I think the core touch point has to be a reinvigoration of the role of government in that convening.
I think these are great points on governance and the accountability mechanisms. And what you say echoes very, very well with this Lusaka process that's been going on, where a lot of countries, NGOs, other actors have called for a reform of the global health initiatives, the large institutions, arguing that the Global Fund, Gavi, PEPFAR, they've saved millions of lives. But the architecture wasn't sustainable. It didn't create the accountability mechanism between the government and the citizens of each country. So I'd like to hear your perspective on that.
Can I go in on that one? The Global Fund. You know, when the Global Fund was formed, the idea was that it meets every country halfway. You put in money and we meet halfway. However, the implementation became something else. Some countries, when you ask them, what's your budget? They will say, oh, we are waiting for the Global Fund. And that became their budget. So that its implementation right from the very beginning was really the one that was off. And I used to say that to my fellow ministers, to say, look, you better talk to a minister of finance and your president to ensure that there is money that is devoted to health, rather than rely on the Global Fund, because it can collapse anytime. And indeed, a few years ago, there was a time when it had collapsed, and there were countries where there were no condoms or anything like that. So that it was really its implementation on its own. The idea was really great, but it did not follow the reason why it was instituted. Yeah.
Oh no, I think we've said enough. Thank you. I appreciate that.
I think we should, let's open up for questions from the audience, both those of you who are online and those of you who are here. So please.
Okay.
And please direct the question to one.
Over there. There's one over there.
Yes.
Thank you so much for the amazing discussion that you did. It's quite like really important, and I do believe like what you highlighted is quite amazing, especially in the aspects of mobilizing the local resources. Building on my experience, it's a bit like unfortunately like a bad one. I'm Sudanese, and I witnessed the war in Sudan, and you can imagine the amount of neglect this crisis has been facing throughout like the previous 2 years. We are talking about like more than 20 million people have been affected, yet unfortunately, even in this discussion today, in the previous one, we didn't even talk about Sudan specifically. So this is a crisis that we dealt with, and this is a situation that we jumped at. And I also wanted to be more positive in terms of as we speak right now, we are talking about diversifying the funding channels. And what I wanted to add to the table may be the diaspora role. The diaspora role is quite huge. The organization that I'm currently representing is doing a lot of resource mobilization from different communities all over the diaspora groups from the Sudanese community, and managed to secure more than $20 million throughout this crisis, which is a considerable amount of fund.
It's huge.
We are a bit exhausted right now because people at emergencies are flexible. But we do believe like this, especially looking at the current situation, for example, the Sudan humanitarian responses in 2024 was around $4 billion. Only half of it has been funded, and most of this fund actually came from the US. This is a fact that we are currently dealing with, but we are looking at this funding channel as an opportunity to be like somehow more structured and more organized. So based on your experience, how you previously engaged the diaspora community in a more structured manner, how did you for example, localize the resources for those diaspora groups in a way that first of all make them trust the system, whatsoever it was, like a nationwide or local. Adding to that also, how did you somehow, or thought about it, engaging them more in a more regulated manner. And the last thing, which is also important, because looking at the US, for example, most of the resources that we are sending to Sudan is not reflected, for example, in the taxation module. So how could be somehow also be like a different channel of fund that could be utilized, looking at the fact that this global shift is not only a US thing, rather than it's a global thing. Thank you.
Thank you for those reflections and the challenge. And Lois, I think you can respond.
Yeah, I'd love to try to respond to that. Thank you for, first off, raising Sudan, because obviously that has been a crisis that I won't say it's been completely forgotten, but it certainly has been overshadowed in ways that it shouldn't have been. So thank you for lifting that up. I also really appreciate you focusing on the diaspora. A few ways that I've seen the diaspora mobilize or be engaged, including in how you described, just through funding, remittances. I mean, we've all seen the data on remittances. There's a lot of money that goes back home. And there's some interesting ways that people, I think, have been and continue to think about those funding flows. But in terms of how it gets beyond the money, I know I've seen people engage in advocacy initiatives in the US or in other sort of donor countries, we called them up until this year probably. And I think that's been important because for a couple of reasons, because it's helped folks across the diaspora understand some of these existing programs in which they could fight for investments, but then importantly also tell the story more directly about how their communities or countries are being affected, or what more is required, how we shift how we do business. And that gets to another way I know that during the Biden administration, we really looked at how we engaged the diaspora through policy, informing our policies. So there was the first ever President's Council in Africa that was convened before the U.S.-Africa Summit, which I think was really well received by folks in that diaspora community. I think we've seen similar examples around the America Summit and how we try to engage those communities and on and on. And let's not forget that in Congress, you have also these groupings like the Congressional Black Caucus, the Congressional Hispanic Caucus. You know, they are another way for us to pull together, at least in the US context, but possibly also in places like the UK and Canada and elsewhere, these communities who really care about the world in a very personal sense. Those are just some initial ideas. The other thing I would say, you didn't mention this outright, but because I didn't hear it on the last panel, I also wanted to lift up the BRICS. Because, you know, these conversations, there's some question about like, what do we do about the US and like G7? The reality is this conversation is happening in other settings without the G7, appropriately so, one might say. And you know, there are already sort of these groupings of countries or communities who are saying, okay, well, we want to fill this, and we've wanted a slice of this for a long time, and now we have an opportunity to actually show up in a different kind of way. So whether it's through the BRICS summits or looking at, you know, sort of MENA as a region and how they can step up, I think we're going to see and hear some really interesting opportunities for investment, for lack of a better word, by new and different actors.
Thank you. Other questions online?
So this is a question specific from a participant who is from Myanmar. This participant says they are undergoing a current grappling of a confluence of crises in the country, the political situation following the coup, ongoing conflict, and impacts of recent natural disasters like the earthquake and much more. And it's left a severely fragmented health system, and many implementing partners are heavily reliant on donors like US aid in the past. And given these extreme constraints and current political contexts, could you share your perspectives on the most critical initial priorities for beginning to rebuild essential health functions?
That's a tough one. Who would like? Eric.
That's a tough one. Myanmar has been really thrown from one issue to another with a history of unresolved issues still being present. And the United States, I guess it was in 2010, kind of reintroduced a diplomatic relationship with the country that looked at a robust expansion of PEPFAR programming in the country, and USAID, CDC, NIH, all converged on the country for about 6 weeks to understand it specifically and try to transfer capability rapidly. And that was Secretary Clinton and President Obama's desire to do that. They made it a real priority. I can say that it fell short on every level in the long run. It was clear it wasn't going to get traction while we were actually there, and the political leadership did not precipitate out in the way that was anticipated by the US government. So it went a different route. I think that the multilateral NGOs, MSF in particular, still has a vibrant footprint there in the TB arena especially, and go up into the north, north region as it matches up against China. And I think those are clinics that are connected and still funded as of maybe a month ago. So I'm not sure about the others. The delivery system in the country has never been responsive in the way that you're referring to. So.
Well, I think it boils down to what I was saying. The fact that, you know, there are certain ingredients that have to be there at country level for any one donor to be able to see progress or to feel that impact and influence. It's peace. It's zero tolerance for corruption. And it is also what good governance right there. That is accountability. So, I mean, you talked about Sudan. And one of the things you said was they are tired. They are tired because maybe they don't even know where the money is going to. Is it perhaps be funding more rifles You know, so if there is no, that good governance is not there, nothing can happen. I work with the Ghana nurses in the diaspora. And every year in January, they all congregate into Accra and they bring nurses who did not leave. These are nurses in a diaspora. They come and they give training, they give scholarships. So they see the tangible results of what they do. And in fact, as a result of that, it's now continuing, and I've been able to get them in touch with other African nurses so that we have the African Diaspora Nurses, Alliance. But it's simply because they're doing so where they can see that whatever they put in, there is something that comes out that is positive. So it's not easy. Yeah.
And I think these two comments about Sudan and Myanmar, countries at war, catastrophe, risk of infectious diseases spreading and so on, and Dean Daly talked about this morning that this situation is also a security crisis. Can we talk a little bit about, now we see defunding of WHO, of what many call the global public goods, surveillance systems, pandemic preparedness and response, what's happening there. Who should invest and what are the key priorities for upholding and investing in these global public goods? Yes.
I'll make a plea for research, because I don't know if we talk about that enough. Speaking of global public goods, the scientists have saved us time and again. I love my implementer and practitioner community, and the people behind the benches don't necessarily get enough love. So when I look at our Department of Health, for example, you hear a lot about our Centers for Disease Control, rightfully so, and not enough about our National Institutes of Health, which there are 27 or 28, right? Not enough about our Food and Drug Administration, which also is supporting the African continent in their latest sort of regional version of an FDA, or had been. So those are the types of investments I think we need to be sure we also are making so that we have some shot at ongoing innovations. And they don't have to be in the US institutions. In fact, again, they probably shouldn't be, right? But there were in play sort of these regional networks and initiatives around research in which the US had heavily invested over time. And I don't know what's going to happen with all of this intellectual prowess, someone should do something with that. And there are plenty of companies, if no one else, who have a lot to gain by investing in this. Now, I'm not necessarily going to pitch one plan or another, because I think that comes with its own challenges, right? To have it be sort of a for-profit structure. But the reality is we need this science, and we need to do something with this science, and we need to advance this science. And so I really am hopeful that is a global, that will, one, be seen as a global public good increasingly more, but also, two, that someone or some ones take up that investment as well, including and especially at the regional and local levels.
I'm very happy for this message.
Yes.
Eric, do you want to comment?
I would just amplify that message. I'm happy for it too.
Okay, great.
The lack of a greater good discussion and target in the global discussion is clearly missing, and tragic that it's missing. It's missing from our domestic discussion as well in health. We don't do things for a greater good reason. We do things for profit. And that locked in for-profit expansion motivation is the motivator that we need to manage the most. And I think that the counter to that is looking at how governments manage the needs of the populations they're responsible for. They can't forget they're responsible for that population. They abdicate that we are no longer responsible for your health care, and they've convinced people that governments aren't. And that wasn't the case in my lifetime alone. I've seen that evolution go very quickly to, oh yeah, that's reasonable to say. It's not reasonable to say. We've lost ground to allow it to take the space. So a greater good discussion is what motivates most of us and should come back to center plate as the central motivator for why we get up and do the work we do each day. And I think it really puts that umbrella over global health, medicine, science, and the research motor that feeds it all. It's all connected.
Yeah.
Thank you. We have time for a couple of more questions. Anyone in the room who would like to ask this audience? Yes, we have Lisa Robinson over there.
Wondering if, I'm not sure if I'm close enough to this, I'm wondering if you could comment briefly on the role of interventions outside the healthcare system, efforts to decrease air pollution, climate change, both within countries, the coordination across ministries, but also the role of the U.S. as we pull out of climate agreements and other things like that.
I can just say such a tragic juxtaposition, and the climate challenge that's in front of us is the homogenizer of all of the issues we look at. That one can come in and tsunami us, and it will. And all the data has shown us that it is crescendoing, but we have not allowed ourselves as governments and as a global community to realize the urgency of it. Yeah. I think that awareness is rising up kind of week by week and hasn't got conscious yet. But when it does, I think there's going to be a reequilibration of whatever we decide in our current discussion around the global health response.
You know, I really appreciate this question, and I want to pull a thread from the last panel as well. Dr. Corey was talking about how we really need to rethink how we approach health. And, you know, this is an ongoing conversation. The pendulum always swings between silos and systems. And just by necessity, we're going to, I think, have to come together differently across health issues, but across all issues. If this was a huge part of the conversation, especially in the wake of COVID, where finally the climate and health communities were like, oh yeah, we've been meeting to call each other. I'm so sorry about that. And so I think some of that work is picking up again, whereby, you know, and I know people like Dr. Carey are involved, you know, here and is ringing this bell often. But, you know, leveraging these connections between issues, and especially as someone who used to work in non-communicable diseases, I get it. And I had a hard time getting other people to get it. But now, you know, with COVID and now with sort of everything collapsing, I think we are looking around to see who our friends are. And they're not just in this room, right? They're not just online, but there are plenty of others who are focused on everything from climate to conflict to, you know, all things human. And so yeah, really grateful for the question. And again, I think we all should, you know, if not get smarter about some of these connections, be open, be more open to, you know, making those connections.
Yes, one more here, please.
Hi, yeah.
Please say your name and.
Hi, my name is Sonali, and I previously worked at Google Health AI, and now I work in a different AI company called Verily, and Boston is the hub for biotech and technology innovation. And I think we've talked a lot about collaboration, right, across different, whether it's technology, whether it's outside of the hospital system. And I've heard about different opportunities, right, these glimmers of hope, whether there's challenges around resource mobilization for maybe the areas that are the most impacted or hit. And I guess one of my roles is helping our leaders define what problem areas we may want to focus in by bringing in subject matter experts, by bringing in patients, clinicians, et cetera. And I'm curious if each of you or one of you could even speak to like a few questions or areas where you think technology may play a role. This could be maybe you have an idea, but also just maybe the hardest questions that you have to ask yourself that data could even help support.
Yeah.
And it's a little bit more focused, but it would be helpful for me.
Well, I think one area where technology will play a role is really in pandemic preparedness for the world. I mean, right now we have a treaty that still has to be signed at Geneva level on pandemic preparedness. But a lot of countries are either not aware or are just not willing to be partners in that. So that kind of research, that kind of technical collaboration would help a lot to be able to say, look, if you don't do this, this is likely to happen. COVID did show us that we are vulnerable. But I guess there was also the element of, what should they say, me for myself, in that if you look at what happened, the West got the medicines, the vaccines, and injected themselves. And we were left like, what is happening? So, people always say, how did Africa survive in that thing? And I say, it is only by the grace of God. Now, being a Catholic and working well with the Pope, I know it was only God who put his hand and said, well, no, you're not going anywhere. Why? Because between the Western world that didn't care and our own leaders who had no clue, we could have been decimated. And a lot of projections were there that Africa is going to be decimated. No, we are alive. We are fine.
Exactly.
So really, but we do need that. Yes. So thank you.
Eric, please.
You make me think of most of the kind of technical data need you guys seem to be focused on already, and doing a good job with it. But if you could work on why is it that we can make a discovery, be it a drug, be it a diagnostic, a therapeutic discovery that treats and cures a disease, and we cannot figure out how, as a delivery system and as a society and a global community, how to get it to the person who needs it.
Yeah.
How pathetic is that? Put your thoughts on that one.
Please.
The pursuit of a profit margin isn't the answer, as that's the justification, so that's okay, and we can continue to do it. We have to harmonize that with the carnage it creates and the responses unmet that we're looking at in Boston, in the United States, in every major metropolitan area in this country. Those disparities are evident and measurable. And many people in this room have spent many big chunk of their career documenting that. Documentation is where the discussion begins, never ends there. It often doesn't even give you the conversation, but maybe you guys can figure it out.
Yeah.
So.
Thank you very much.
Oh, sorry.
Yes.
Can I make one final play
Yes.
on tech? Yes, and yes. Obviously, mis and disinformation is a big part of that too. So to the degree to which you all are, able and willing to work through that, can only underscore. Also, we've seen, just building on the emergency preparedness piece, we need more better early alert systems, and not just for the authorities, but for the communities. I'm thinking about like yellow fever on the rise in Latin America again, which is really scary, on top of dengue and many other things that we're dealing with in the region. So what does it look like for, decision makers at the individual and institutional level to understand what's happening so that they can get vaccinated or otherwise protect themselves, so that we can understand the potential impact on health systems, where are the health workers, right? Like, what are the other needs that are required to address this and other issues? And we can sort of rinse and repeat for climate disasters, for migration, which, by the way, we have no idea where all the migrants are going, right? And what their needs are when they're on the move. But like, those are like these big problems that without boots on the ground, we really need technology, and AI in particular, to step in and help us.
Thank you very much. We're moving to a close. Jennifer Leaning said earlier today that she didn't want to end on a positive note. So I will ask you, I'll give you 30 seconds each. Okay. A very existential question. Do you think this area of global health, global development aid, overseas development aid, research in global health, will it exist 10 years from now?
Hey!
I would say yes.
Eric can start.
Okay.
Yes.
I would say it will. Global health is happening all the time, everywhere, whether we acknowledge it or not. And how it occurs really is dependent on how it plays through an individual's ability to access a delivery system that can diagnose and treat diseases that we already have completed the science for. How pathetic is it that we cannot get the people who would benefit from the science in front of it? The tragedy of that reverberates through all of our institutions, all of the systems we interface with, and is a challenge that we all have to accept. I think academic institutions in particular have to keep their thinking and their speaking clear, because they are an example to the rest of society as to how one should model behavior in trying to juggle these resources that are not ubiquitous. So difficult decisions need to be made. We want smart people to make them, the best informed people, the most compassionate people, and the people who have a line of accountability to the decision they make. So if it's wrong, they're held accountable for it.
I like that. Lois.
That's right. I would say global health will exist, but be more local again, and Southern or solutions from the South will be seen as success. That's it.
Very succinct. You'll get the final. You got the first word, and you get the final words.
Okay, my final word is, yeah, global health will exist, but it has to start at country level, from the community all the way up. Because right now we still have, systems that are not working. So it will exist, but we will need you, the researchers, to be able to do to look at what can be done and hand it to the legislators, the decision makers, in such a way that they can understand the way forward. Sometimes academic papers are really something else. You look at it and you think, so what? But it needs to be condensed. If I'm a minister and you are giving me your academic paper, please condense it into 2 pages that are saying, I found this, you need to do this. Yeah. That will happen. Yeah, thank you.
Thank you. Let's give the panel a hand.
Thank you so much to our panelists. Really such a rich and thoughtful discussion to help us ground the complexity of this moment and what's possible moving forward. So another round for applause, and we're getting ready for our following conversation. Thank you so much. Yes, thank you. So now I would like to introduce our next conversation. We're going to take just a minute to set up our stage. I particularly am really looking forward to this. How can a 21st century online social movement advance global health equity? This will be a conversation with best-selling author John Green, whose newest book, Everything is Tuberculosis, is on its 3rd week as New York Times bestseller. Moderating this session is Carol Mitnick, Professor of Global Health and Social Medicine at the Harvard Medical School and Associate Epidemiologist at the Division of Global Health at the Brigham and Women's Hospital. I now invite our team guests to take the conversation forward. Thank you so much.
Great. Thanks so much, Carol. Thanks, Louise and Carissa, for organizing the event. And what an honor to be here today with John Green. I think this conversation is going to be a little bit of a digression from what you've heard so far. I'm not sure it will so much be an antidote to the despair and misery as much as some hopeful opportunities and actions. I want to start with just kind of a global health origin story. So everyone in this room, and I think online, has a global health, or as I know you prefer to call it, John, human health origin story. My best friend from childhood would say that mine was because I was looking for a cause that spoke French. Upon graduation from college, I had studied political science and French. I had no useful skills, but I was deeply, deeply concerned about inequality in the world. And I thought the only thing I can do is communicate into the languages of the colonial powers, English and French. So I'll go work on malaria in West Africa, was what I thought. And through a series of events that were unplanned, probably most transformatively, no, not probably, definitely most transformatively, meeting Paul Farmer, I ended up working on tuberculosis in Peru, and I didn't speak a lick of Spanish. So could you tell us your global health or population health origin story? And if people who are online would like to type theirs into the Qualtrics form, just so we can see some of the other stories, that would be great.
Yeah, so I guess mine begins in childhood. I mean, I grew up with 2 parents who worked in for nonprofit organizations and were community activists. And when my book became a bestseller, that was not impressive to my parents. When my brother and I became famous YouTubers, that was not impressive to my parents. They were not particularly proud of us for those achievements, such as they were. They always wanted us to be active in our communities and to be responding to the crises as we saw them. And so, Hank and I from the beginning, that's my brother, Hank, my brother and I from the beginning of our careers making stuff online and making stuff together have been thinking about how we could have an impact outside of our, narrow worlds. And that eventually became Global Health. But I think with tuberculosis in particular, it happened because I was, in Sierra Leone learning about maternal mortality and learning about the maternal health system in Sierra Leone. And on our last day there, we visited a tuberculosis hospital, and I had no idea that tuberculosis was still such a crisis. And while I was there, I met a boy named Henry who changed my life because I came home obsessed with TB and have been obsessed with TB ever since, trying to understand why I was so ignorant, why my information feeds had failed so badly that I had no idea that TB was still the deadliest infectious disease in the world, or that it was killing 1.25 million people a year. What was wrong with my Twitter feed that there was no information about that? And it turns out that there was something profoundly wrong, not just with my Twitter feed, but with the Twitter feed of the vast, vast majority of Americans.
Thanks, John, for that thought. So let's follow that thread in your fascination with TB. You really have become supremely well informed about TB. Can you just share a few points with this audience that does a ton of work in global health, but not everybody here does TB, of why you think TB, why it's really captured your attention and why it is the ultimate marker of inequality?
Yeah, I think that's exactly right. It's the exemplary disease of injustice and the exemplary disease of healthcare inequity in our world today. It's certainly not the only one. Malaria is a disease of injustice. HIV is a disease of injustice. Diabetes is a disease of injustice. If you map poverty in my hometown of Indianapolis and you map cancer rates in my hometown of Indianapolis, it's the same map. So you don't have to go to Sierra Leone to see these profound healthcare inequities. We see them in the United States. We see them throughout the world. But for me, it's tuberculosis because tuberculosis has such an important part of our history. It's killed about 1 in 7 people who've ever lived. It was a disease that existed before we existed. It was part of the human story before Homo sapiens were part of the human story, most likely anyway. And because it's had such a profound impact on my life, I mean, my great uncle died of tuberculosis. I just noticed your socks. You're wearing socks made by my brother. Thank you. Those socks go to benefit maternal mortality.
Speaking of which,
in Sierra Leone to fight the maternal mortality crisis there. So thank you for wearing those socks. But tuberculosis, at the height of the tuberculosis crisis in the United States, there were almost as many hospital beds for TB patients as there were hospital beds for all other healthcare conditions combined. That's how big of a problem TB was in the United States in the late 19th and early 20th centuries. Even the ambulance is upset about it. And so this is the history, but then there is this terrifying present of tuberculosis, which is also a result of history, or also a result of historical forces, a result of colonialism, a result of centuries of impoverishment, a result of capital flows that go one way and not the other. And I wanted to understand all of that and how all of those forces shaped the life of this one young person I really care about. And, we're all a result of historical forces, of course, but seeing that in Henry's life, as was mentioned earlier, how does a disease that's been curable since 1956 infect and potentially kill someone in the year 2025? That's not a failure of science, although we do need better tools to treat and fight tuberculosis. It's a failure of human-built systems. And so I think what fascinated me was this idea that the cause of tuberculosis in the 21st century is not ultimately deep down Mycobacterium tuberculosis. It's us. It's human-built systems. It's the world we've built together. And that means that we can also be the solution. We don't need to wait. I mean, we do need to wait for better vaccines. We need to wait. We need better diagnostics. We need better drugs. But we have the tools now to end the tuberculosis crisis. And the fact that we haven't done that really fascinates me, I guess, but in a horrifying way.
Yeah, and I think to hearken back to some of the last discussion around the importance of research, the point that you highlight about we can make enormous advances with the tools we have today. And I agree with you. I think we could eliminate tuberculosis with the tools we have today. It would take a lot longer than if we had new and improved tools. And so keeping the pipeline flush with tools is going to be critical to an end of this pandemic in say, the next 25, 30 years.
Yeah, and not to increase the number of bummers today, but one of the devastations of the way that we've cut back not just on global health funding, but also on research, is that many of those tools that were right around the corner, including potentially a tongue swab test for tuberculosis, that could be huge. Better vaccine candidates. I mean, the only vaccine we have for TB is 105 years old and not particularly effective. I mean, that's an exaggeration. It's not at all effective except in preventing severe illness and death in some children. You know, these tools are not as good as the tools we need, and we're on the cusp of better tools, and a lot of that funding has also dried up, which is just devastating for those of us who care about TB. But we're also seeing that with HIV. We're seeing it with malaria. We're seeing it with other diseases as well.
Yeah. John and I are fresh off a plane this morning from DC, where we attended the 10th annual TB Hill Day in DC. This has been an extraordinary event organized by a bunch of advocacy organizations and TB survivors over the last 10 years. And thanks to John's engagement this year and that of many of his followers who dubbed themselves TB fighters, the number of meetings with representatives, with members of Congress and their staffs went from 30 last year to 210 yesterday to talk precisely about these issues of what these cuts are doing to humanity today and in the future. Can you tell us a little bit about why you chose to participate in the event, how you think it grew to dwarf all prior TB Hill Days, and what we have to learn from the TB fighters who volunteered, most of them self-funded, to do this advocacy work and did this just extraordinary planning and content development for the day?
Well, you have to build, advocacy doesn't get built in hours or minutes. It gets built over years. My brother and I have been making YouTube videos for 19 years, since, you know, before some of the people who watch those videos were born. And so that's a community that's grown strong over a long period of time. But the other thing I'd say is a lot of times when we look for community advocates, we look for really famous, like we look for the most famous person imaginable, right? We're like, man, if Taylor Swift were on our team, then it would really be a game changer. And I think the truth is, and this is nothing against Taylor Swift, because I'm terrified of her fans and I don't want to offend them, including my daughter. She's an incredibly powerful person and leader and everything. But Taylor Swift's attention is going to be pretty fractured, right? Like Taylor Swift's probably not going to make her new album about tuberculosis, even if she becomes a TB advocate. I'm in a position where I can make my new book about tuberculosis. And so I think finding the person finding the folks who are at the sort of the right place, the folks who've built long-term communities, and not necessarily huge ones. You know, like our community, we're not by any stretch of the imagination the most successful YouTubers. Like we're very far away from being Mr. Beast. I think my, you know, I made a video last week that got like 95,000 views, which is, for context, is not a lot in the world of YouTube. Like that makes you about like $200. So. If you can live on $200 a week, you can live on my YouTube salary. But most people would struggle to do that. And so, you know, we're not huge YouTubers who are making millions and millions of dollars off of YouTube. But we are people who've built a long-term community, and that community showed up in a big way on TB Hill Day. And but I want to emphasize that, like, as they say, they have a founding document that they wrote that's 100 pages long, and the first sentence of it is, "We lead by following." And so, you know, that's a group of people who understand that they need to pay attention to the survivors, to the advocates who've been doing this for 10 years, the folks who built those relationships on the Hill over the last decade. And yes, we can get way more meetings now, and that's super important, but we also need to understand that we're only getting those meetings, we're only in this position because those folks did that work for the last 10 years.
Yeah. No, it's a very important point, and the humility of all involved has been really striking, and the willingness of very disparate groups to work together was quite a sight to behold yesterday and in the planning.
Yeah, it was awesome. Some of the meetings were great. Some of the meetings were really encouraging. Some of the meetings were a little depressing. But it was on the whole a really encouraging experience. And just, I don't know about y'all, but like I wake up a lot of mornings just staring at the ceiling and feeling like, what the actual F? Like what the hell is going on? And like I just want to stare at the ceiling and stay in bed. And that turns out, of course, not to be very effective. The problem with despair is that it's like a replicating bacterium. It only makes more of itself. And so my temptation, I've always been tempted by despair. I've struggled with depression throughout my adult life. And so my temptation is always to just kind of give into that and stay in bed and doom scroll until I, feel like going back to sleep again. And that, of course, is not the right strategy. And being in this room is a reminder that that's not the right strategy. So.
And I think yesterday.
Yesterday was a reminder as
yeah,
well.
Yeah, and to speak to some of the earlier conversations about making our voices heard, about speaking to our legislators. This was just one step in a very long process, especially given that it was the first year of a new Congress and a Congress that seems to have abdicated quite a bit of its authority. That was a repeated message that we heard in meetings was, it's not in our hands, it's in the administration's hands, or it's in the judiciary branch's hands. And that included meetings on the Republican side of Congress. So that was, on the one hand, totally demoralizing, and on the other hand, it was a good reminder that we were there to begin to build relationships, to begin to offer resources for people.
Yeah, hand out some copies of the United States Constitution that makes it very clear that that's not the case.
So I want to go back to what you mentioned about the TB fighters' mantra of leading by following. And one of the things that I've noticed about you is, in addition to being a profoundly talented writer and vertical video sensation, with the skill of really using those platforms for change, more importantly, you're an extraordinary listener. And you've listened to and honored Henry Ryder's desires, the person whose experience you describe in your book, for his family, his compatriots in Sierra Leone. You've talked about his YouTube channel, and he's promoting, he's advocating for improved water conditions. There are huge water scarcity problems in Sierra Leone, and you've really centered him in your advocacy work. And I've been with you on countless calls with TB activists, and you also just listen very, very deeply and thoughtfully. Can you, I guess, reflect a little bit on what you've learned learned about the movement for global health equity by listening, or maybe conversely, what you've learned about listening from the global health equity movement?
Yeah, so much depends on whose voices we center. You know, I mean, Henry can't be here because he was turned down for a visa.
Right.
And that's often the case with people who live in impoverished communities. And so but I also can't speak for Henry. I have to find ways to lend him my megaphone. And I have to find ways to lend other people my megaphone. Is lend the right word, or am I actually still then holding on to the megaphone? He realizes mid-sentence. I think that's a very interesting question. That makes me feel like maybe I'm still clinging to the megaphone a little bit, which is something for me to think about. But I have to find ways to center other people's stories, and to do that, you have to listen carefully. Listening is, I think, the human superpower. It's the way that we can understand each other's experiences. There are all these gaps in empathy, right? Like 155,000 people are going to die today. And if I felt the loss of each of them the way that I would feel the loss of one of my parents, I wouldn't be able to function. And so some level of empathy gaps are inevitable and natural and whatever. But like empathy gaps are often used to kind of justify horror, or to go on living in the face of horror without being horrified and without being outraged. And of course, like, outrage isn't a completely sustainable emotion, and we can't feel that all the time. But it is very important to feel it. It is very important to understand that. And for me, listening, like reading, like other forms of shrinking the empathy gap, is a way to understand someone's experience with a little more clarity. The biggest bummer of being a person for me is that I'm stuck for the entire time that I'm here inside of this one skin-encased bacterial colony, and I can only see out of like one set of eyes, and I only have one consciousness and one set of experiences, and I have no idea what it's like to be you. I don't even know what it's like to be my children. Like, even the way I talk about them is in the context of me, my children, my spouse, my best friend. And so, you know, if you're talking about somebody in the context of yourself, like, you're not really imagining what it's like to be them with much clarity. And it's really hard to imagine what it's like to be someone else. But I think listening is the only kind of path that we have.
I really appreciate that.
We've got so much bacteria in us, Carol. It's very stressful for me.
Do they listen too?
Huh?
Do bacteria listen?
They think for us, which is messed up and upsetting. Yeah, I recently spoke, in fact, one of the TB fighters is a gut microbiome scientist, and she was talking to me, and yesterday, she was like, you've got to start thinking about your microbiome differently. It is your friend, not your enemy. And I was like, half the cells inside of my body are not mine. Like, that is upsetting, and it should upset everyone.
They're your friends.
Yeah, well, we have to move on. We're talking about inequity.
And we're going to continue on the storytelling part of it. So whenever any of Paul Farmer's thousands of mentees talk about a too small sample size as an obstacle to generating evidence, he would wryly refer to the N, or sample size, of his dissertation and then book, which was 1. I've heard you talk in interviews about Catherine Boo's incredible immersive journalist book, Beyond the Beautiful Forevers, which is really this, for those who haven't read it, just this searing story of suffering among residents in a non-notified slum in Mumbai. And in Everything is TB, you really bring Henry Anisatu's life to your readers. You allow people to think about him and to know him and his experiences and the forces that shaped it. And knowing that in this community, I can see a large group of quantitative researchers over here, and I am sure there are many others here and online. And these are people, we use quantitative data to try to tell stories of inequalities. Can you talk to us a little bit about why it's so important to use the personal stories and how that works for you better than the numbers?
Well, I have to say it's very important to have quantitative research. I mean, it's extremely important to know the numbers, right? Like, and this is part of the current horror, I think, is that in many cases, it's not just that many more people will die of tuberculosis and malaria and cholera and other diseases. It's that we may not know how many more people die of these diseases because also we've cut the grants that count and that do the literal counting. And so that is its own terror for me. The idea that those lives go uncounted, or that we have to find different ways of counting them, I guess. So I think that's super important. Like, it is very important to understand how many people get active tuberculosis every year. It's very important to understand how many people die of tuberculosis every year. That said, it is incredibly difficult for human beings to understand the difference between 10,000, which is the number of cases of active tuberculosis in the United States this year, and 10 million, which is the number of global tuberculosis cases. I mean, y'all can do it because you're literally quantitative scientists, but like, most of us can't do it. And what moves me, ultimately, is the story of human beings, the stories of individuals, human beings who have the same, their lives have the same value and complexity as my own life, and their griefs are as profound, and their love is as profound as my own. And to understand them and glimpse their reality is transformative for me. That's how I shift in my understanding of the world. That's how I shift my allocation of my personal resources. And it's how I've found that you can shift other people's allocation of their resources. And I don't just mean money, I also mean their attention, their time, and their care. And so that is why ultimately, like, I do cite a lot of statistics in the book, but I wanted to tell Henry's story in particular because, one, Henry wanted me to tell his story. He asked me to tell his story. I mean, I could have written a novel, but Henry would have been very mad. Henry wanted me to tell his story. And two, Henry's story deserves to be told. Every story deserves to be told.
No, I really appreciate that. I have to say it's something for me. I don't really feel authentic telling other people's stories. I see a lot of my clinical colleagues do that, and I somehow feel like as a non-clinician, it's not my place. I'm still working on that.
It's really hard though, Carol, because you also have to remember that like you're going to inevitably bring your own lens to it, and when that lens is also a colonial lens and also a global North lens, that's a thing to be very, very worried about. And so when I was working on this book over and over again, I would go to Henry and Isatu and say like, do I have this right? Like, here's what I wrote. Do I have this right, or am I misrepresenting something or failing to see something? And there was so much that I did misrepresent and that I did fail to see. And so, you know, I hope we got there in the end, but it was challenging.
You've talked a little bit in this context about that it was important to you to represent the complexity of their lives, of Henry and Isatu's life, Isatu when she was growing up. Can you say a little bit about that?
Yeah, I mean, so many narratives are so essentializing. Like you read these case studies, and I love a case study, man. I actually really like those papers that were just being made fun of that are like 17-page long case studies. I love a case study, but you read those case studies, and a lot of times it's like this person's a 37-year-old male who has a history of being unhoused and a history of this and a history of that, and I'm like, man, there's a lot that I'm not finding out about this person. There are a lot that these offer me more questions than they offer answers, frankly, and so it's really hard not to tell essentializing stories about other people because we have this problem where the only person that I get to be is me, and so I inevitably sort of essentialize your story, and I see you as a little less complex than I see myself because I'm not stuck inside your head having all the multitudinous thoughts that you're having. And so I did want to fight against that. There's this great Nikki Giovanni poem where one of the things she says is that she hopes a white man never writes her biography. But in the poem, she talks about how one thing that they never talk about in like newspaper coverage of her and her work, they talk about how she was poor. They talk about how she lived in Chicago and how she didn't have hot water. And they talk about this and they talk about that. And they never talk about how she was happy. They never talk about how much she loved having all of her mother's attention. And so I tried to do, I mean, who knows if I succeeded, but I tried to do that in the book.
Yeah, no, I appreciate that reflection. I'm going to go back to numbers in kind of a weird way, but you mentioned the 95,000 YouTube views, and you've sold, I don't know, tens of millions of books, certainly millions.
Yeah.
Tens of millions, maybe across the books. You've got 4.3 million followers on a platform that you've now disavowed, 2.2 million and 213,000
I used to have way more Twitter followers, actually, before I disavowed it.
Yeah, well, this was just yesterday.
Okay.
And you know, millions and hundreds of thousands on platforms that you use daily. And I'm sorry, I told you I don't subscribe to TikTok, so I didn't know how to find how many followers you have on TikTok.
I don't know how many. I also disavowed that platform.
Okay.
I disavow them left and right, and then I reavow them. Y'all know how it is.
So can you reflect a little bit on what you and Hank have done over the years and why you think so many people have been keen to consume that content, kind of how you got there and how it morphed either within or despite your control?
I think it morphed mostly despite my control. You know, it's really easy to see these things as single directional, like a person makes content and another person consumes that content, and that's the relationship. But the relationship is so much more complicated and interesting than that. In fact, the person who's consuming the content is also shaping the content through their comments. They're also shaping the content through watching it all the way through or halfway through. They're shaping the content by you know, encouraging you in sometimes polite, sometimes impolite ways to make different kinds of content. Why aren't you talking about this? Why haven't you talked about that? Like, have you thought about this angle? And so it's much more multi-directional than I think we usually give it credit for. And I also feel like I lead by following when it comes to our audience. I mean, they've really brought us to global health in many ways because we realized pretty early on, like we started making YouTube videos in 2006 or 2007, and we realized pretty early on that people weren't all like us. They weren't all in America. They weren't all living in the Midwest. They weren't all, you know, you know, dudes who just got married, like, and so we had to make global content because we had a global audience. It was immediately clear to us that, like, I remember once I made some like offhanded comment about Zambia, and somebody commented, "I'm Zambian." And I realized, like, oh, right, of course, like, people watch us all over the world. And so, like, if we're gonna have if we're gonna build stuff together, if we're gonna do stuff as a community, we need to do that in a way that truly has a global focus, because that's our audience. And it's not just our current audience, but it's also our aspirational audience. We want to reach out to more people. We want to reach out to more communities. And so, yeah, I think that's the reason where we were drawn to global health on some level, is because we were pulled in that direction by our audience.
Okay. Yeah, and I was also just thinking about how this long history of doing a variety of different kind of content, from the educational stuff, from Blog Brothers to silly stuff, how that has informed now what you're doing really, really successfully around global health equity.
Well, it's nice of you to say it's going successfully. I don't know that we can say that about anything in global health equity right now, actually. But
it's getting a lot of attention. How's that?
That's fair. But I do think that so for those who don't know, my brother and I also make this channel Crash Course, which is like teaches high school kids how to like engage with history and biology and chemistry and other stuff. Helps, like, it's not in any way a replacement for a proper classroom, but it's sort of the first, you know, like homework where you can get like a 10-minute introduction to something, and then you go into the classroom and actually learn it. And, you know, that was born again of leading by following, of people saying to us, "You're such an engaging person when you talk about the French Revolution on Vlog Brothers. Why don't you ever talk about world history? Why haven't you talked about the Mongol Empire? Why haven't you talked about pre-Columbian American history? Why haven't you talked about this? Why haven't you talked about that?" And we were like, that's a great idea. And so that's where that show came from. So I think I think it's about responding to the needs of the community.
Very cool. Okay. So in the first, or the discussion that Salman and Petra and others were involved in, there was a little bit of a discussion about the tension between vertical programs. This is a complete change, sorry.
No, I'm ready.
I was following you before. And
yeah, great, let's do it.
The tension between vertical programs that have actually been quite successful in garnering more resources for certain diseases, but have also created problems like others were describing, about kind of creating a false sense, perhaps, of what the confines of TB care is. And you've heard in your PIH experiences the term cheval bataille, the Haitian word for battle horse or Trojan horse, and using what it's used to mean taking a single disease or a single intervention area and building a whole comprehensive kind of package around that. What have you seen to date in your work with TB that would help us to kind of bridge this TB as a vertical program to TB as a more integrated effort that could include Vaccine Day for polio, for example, or the diabetes screening?
I feel like asking that question is like asking the Karate Kid to give Mr. Miyagi advice, but I'll do my best. First off, I'd cite maternal health. So, you know, we have a big project in maternal health that we've helped support, and the Partners in Health has helped support in collaboration with the Sierra Leonean Ministry of Health, which has been a remarkable partner to improve maternal health in the Kono district in Sierra Leone, with a maternal center of excellence, a really exciting hospital and NICU that will transform the kind of care that's available in Kono. But we also have seen, as a result of that, now there's a functioning blood bank. Now there are operating rooms. Now there are more doctors. There's more kinds of OBGYN services available, including services for teenagers who aren't pregnant. So that's one sense in which it can be a Trojan horse. With TB, it can be a Trojan horse because I argue in my book that everything is TB. That TB is everything. TB is malnutrition. TB is HIV. TB is everything. And so when We saw in the United States, we reduced tuberculosis, the burden of tuberculosis in the United States by 90% between 1882 and 1945 with no drugs to treat tuberculosis. And we did that because people weren't as hungry and they didn't live in as crowded conditions, and their lives, their quality of life was better, and they were less likely to develop active tuberculosis. There were still hugely high rates of latent TB, but they were much less likely to develop active disease. And so we saw that by improving the quality of healthcare, the healthcare system, and improving the distribution of resources such that fewer people were hungry, we saw fewer tuberculosis even before we had the interventions that we needed to cure the disease. And so to me, that's reflective of the fact that when we build a stronger healthcare system, we see TB rates go down. But when we build, you can do vertical interventions for TB. They're just not as effective. Right. They're not as effective for TB, and they're not as effective for building the overall healthcare system. And so, to my mind, the most effective is, just like we heard earlier, the most effective strategies are the ones that strengthen the healthcare system and allow us to respond to tuberculosis as the kind of complex, multifaceted disease that it is.
Yeah, and it's so true, because people don't only have TB. They also have diabetes.
You have to imagine the lives of people with TB complexly. And yeah, they have diabetes. They are very likely to be malnourished. I think of the 10 million people who are going to get sick with TB this year, over 5 million are malnourished. And so, and yet we act as if food is not medicine. We act as if food is somehow separate from the world of healthcare, and that food security is not part of our healthcare system. But like, if you've been hungry, you know that that's a health problem.
All right, I'd love to open it up for questions in the audience here and online. Sure, go ahead.
Hi, John. Thank you for centering empathy in the global health conversation. And I'm still kind of formulating my question, so forgive me. But just thinking historically to kind of the post-World War II era, where everyone kind of looked at each other and said, what have we done? And there was this kind of emergence of the UN and these initiatives for human rights and eradication of disease, and basically the idea that we should all care for each other. And I now feel that we're living in a time where human life has become cheap. And I'm wondering, I'm relatively young, so I'm wondering, has this always been the case, and how did we get here? And you've had some success, I think, centering Henry in your story and rehumanizing him in the conversation about eradication of disease. And we're seeing on social media some of the success in the midst of all this terror comes through humanizing people in, for example, conflict zones like in Gaza, for example. But then we also get to the point where you're seeing the same tragedy kind of over and over, and then it just becomes normalized. It's desensitizing. So my question is, how did we get here? Is this just like a normal course of empathy that kind of ebbs and flows over time? How do we rehumanize the global South? It's a loaded question, but I'd love to hear your...
Yeah, thanks for the small question. Well, the first thing I'd say is the year I graduated from college, 2.5 million people died of TB, and last year 1.25 million did. So on some level, we were not doing a good job of valuing human lives the year I graduated from college, which was 2000, at all. We had this pretty much, I mean, we have a few better tools than we had then, but we had a lot of the same tools that we have. I mean, if you get tuberculosis today, you take drugs that were developed in the 1950s and 60s. And so we could have been reducing tuberculosis deaths in the 70s, 80s, and 90s much more. So I think we've long devalued human lives. I don't think that's new. I think you're right that there was a moment of a sort of moral clarity in the wake of World War II, where we built more international systems and said we're going to try to value lives and eradicate diseases. But we've always devalued the lives of impoverished and marginalized people. That is not anything new to the human story. That goes way, way back to agriculture, I think, to like the first cities. I think we've been doing that as long as we've been gathering in very large groups. I am very concerned that we are walking back a lot of that progress through desensitization and dehumanization of other people. And, you know, that progress, which is incremental and infuriatingly slow and unacceptably slow, is still progress. You know, what we've seen with HIV rates and the number of people dying of HIV/AIDS is incremental and insufficient and also real progress. And my fear, and I don't think it's just a fear now, unfortunately, I think it's an inevitable reality on some level, is that much of that progress will be walked back. I think the most recent estimate I saw says that 2 years from now, we're probably going to lose 2 million people to TB instead of 1.25 million. Well, that's 750,000 human lives that, you know, every death from tuberculosis is optional. Every death from tuberculosis is a result of human choice. But that's 750,000 more lives that we're going to lose just because we're devaluing human life. And so I think your concern is real. But I also want to put it in the historical context that, yes, we've always been doing this, but we don't have to do it. And we know that we don't have to do it. And we know that we can understand that we live in one human world with one human health. We just need to build systems that are more equitable, that include more people, that, you know, and we've done that over history. You know, my great uncle died of tuberculosis in the United States in 1930. And when he died, you know, he died because he was poor. Like, he died because he was probably malnourished as a little kid, and that's probably why he got TB, and, you know, so he didn't make it. And we know that we can build systems that include more people because we have a history of doing it. We also have a history of failing to do it, but we have a history of doing it. And so I really believe, and I know this is a little bit counter to the moment, but I believe that hope is the correct response to the miracle of being a person, to the like strangeness of consciousness, to our ability to imagine with some clarity what it might be like to be other people. I really believe that hope is the correct response to that, because I realize that I'm saying this to you, a young person who's been through things that I never went through as a young person. And so it's easy for me, on some level, it's easy for me to say it, but I really believe it's right, not least because the alternative, cynicism and despair and using the shield of irony to protect yourself from all forms of harm and empathy, is not a good alternative. Great question. I feel like I could answer it for the next I hope to answer it for the next 50 years of my life. 40.
Thanks, John. I want to just add one element to Eric's call for AI to improve delivery as equitable delivery. Let's just add equity.
Equitable delivery.
Equity into that.
Yeah, because it's great that we have AI that can read chest X-rays, right? But we need, and this was another question that was brought up earlier. We need to be able to disperse these tools much faster and much better than we're currently doing, so that when AI can be read by chest X-rays, or AI can read chest X-rays, that's not just happening in the richest communities in the world. It's happening at scale in the places where it's most needed.
Thank you. Chris, are there any questions online? Yeah.
So this is a personal question.
Oh, geez.
This was from a individual who is a band instrument repair technician.
Cool.
Who went to DC and met the two of you at a representative's office and senator staff to discuss TB. And this audience member asks how we can mobilize even more people to become deeply invested in TB the way they have become.
Yeah, I mean, it's not just TB, it's got to be everything, right? Like, we can't, the catastrophe of me being obsessed with TB would be thinking that TB is the only disease of injustice or the only cause of healthcare inequity in our world today. And so for me, TB is a way in. It's a Trojan horse. Thank you. I don't speak French. Yeah. I certainly don't speak Creole. So
you can get this one. I'm sure you can.
Schwobatai?
Schwobatai. There you go.
Okay, I got there. So I think I think we have to focus on the idea of healthcare equity in a larger sense, not just on tuberculosis. But the way we get there is we move more people, and once they are moved, they become committed. I mean, that person 5 years ago was probably like me and just didn't think very much about tuberculosis. And now they're flying themselves across the country to go visit with their Senate and representatives offices and make the case for global health funding. Like, that is a journey that all of us can go on, and all of our families can go on. And yeah, if you have the megaphone, use the megaphone, but also all of us have a megaphone on some level. We all have family members. We all have our real life social networks. And it is astonishingly easy to get into the office of a congressperson and make the case. I mean, I was astonished by the fact, like, they'll just see you. They have to. It turns out that they work for you. And so that's what I'd say is get active and tell your friends to get active.
We got at the last visit that I did yesterday, we actually got some deep learning from a longtime representative from the Deep South, who was really encouraging us to not only come to Washington, but also all of the members of Congress are now on a 2-week break, and to be showing up at their local offices now, and to be talking in your smaller networks, to be talking to your church communities. The constituent who was with us at the time has a walking group in the town where she lives. Talk to her walking group about it. So few of at least the Republican members of Congress at this point are having town halls. They don't want to hear any criticism, and so they're not having town halls. And we had a great suggestion from an activist at dinner last night to, intentionally ask them to hold town halls, call them, write them, ask them. If they say no, try a letter to the editor. Local papers are apparently looking for content because they have no content in print at this point. And if that doesn't work, hold a town hall without them, with like a dummy seat where the member of Congress should be.
Classic Clint Eastwood move, if I recall correctly. I think Clint Eastwood did that once at the Republican National Convention, but he did it awkwardly. We could do it in a cool way.
But I think the point is, like, not everybody has to buy a plane ticket to Washington, and there are lots of ways to do things in small numbers.
And ultimately, like, we're moved in part by our social groups, our friend groups, like and so a lot of times we end up with friend groups that are sort of echo chambers. I know I have for the most part, but we are moved by our friend groups and by personal experience. It is different to hear from someone that their own that it's different to hear that my great uncle died of tuberculosis than it is to hear that he didn't. It's different to hear that my friend Henry lived with multi-drug resistant tuberculosis needlessly for 7 years than it is to hear that he didn't. So I think those stories matter.
That's great. Sheila, please go ahead.
Thank you very much. It's great listening to you. Yeah, a white man telling that story. And yeah, I like that perspective because I had a white man write about me in a way that Americans got interested, as in the #1 ladies detective agency.
Mm-hmm.
Now, I'm trying to see, how do I convince you to write about neglected tropical diseases, which I call diseases of neglected people?
Yes.
And which are going to rise because of climate change. So how do you foresee that? Thank you.
Maybe that's my next book. It's very possible. I think it's really important to say diseases of neglected people instead of neglected diseases. I think that's a beautiful statement and a really important one. It may not be me, it may be someone else. I didn't know that your connection to the #1 ladies detective agency, that must be weird. Would be my main thought. But yeah, for me the answer is how do you get the attention of someone with a megaphone in the global north? By making yourself by doing exactly what you've done throughout your career, which is taking every opportunity to speak as loudly as you can and try to get their attention. But you've highlighted something that I think is really important, which is that there is a fundamental disconnect between the places, the places where the megaphone exists and the places where the highest burden of tuberculosis exists, or the highest burden of neglected diseases of neglected people. I'm stealing that, if that's okay. Okay, I'll credit you. Because there's a fundamental disconnect between and that's why if you go on Twitter today, it'll all be about the stock market, and it'll all be about Elon Musk, and it'll all be about whatever it's about, and it won't be about this. And that's very, very frustrating for me. But I think the way that we fight it is one person and one fight at a time.
Go ahead, Mariama.
Mine is not too much of a question, but to join in the fight or to add a voice.
Can you introduce yourself?
Yeah. Oh, sorry. I am Mariama Mahmoud. I am the program manager for TB in Sierra Leone. And I was the head of the clinical team, TT in Henry, and we met at Laka Hospital
I remember.
when you were interviewing him. So I just want to add a voice to this to say that has opened up, being in a country like ours where there are many cases of Henry, like Henry's, young, old, young male who lost their lives, not even just because of TB, maybe the post-TB sequelae, like post-TB lung disease. We don't do anything for them in our country. So we end up treating these people for TB or MDR TB, and then we lose them to some other things like acute appendicitis whilst on TB treatment because there's no surgical center that would take them because they're MDR TB cases. So I'm just trying to add a voice to that and to open a lot of people's eyes about these things. And the focus, it should be on health system strengthening, like we're saying. Having silo, I mean, I am the head of a TB program, but,
vertical program,
which is a vertical program, but I am not very convinced that that's going to work for us, because if we have 14% of sites in our country managing TB, what about the other sites? That means when a TB patient needs treatment, they have to go to specific sites for that treatment. And that in itself is poor access care in the first place. So in this light, I always say TB is not fashionable. It's very difficult to sell TB to people. A lot of other diseases now are a bit more fashionable. You can talk about it anywhere. People can openly talk about them having these diseases. But when it comes to TB, the stigma is still so very strong around it. And you hardly get people really opening up and talking about it. So I'm really happy that you gave this platform to Henry and to TB generally. My concerns would be now we're changing the narratives of who tells a story. It's not just the platform. We're talking about a white man talking about telling a story of a young black boy. So what advice would you have in that space? Like, who tells a story? Who should be able to tell these stories?
Well, first off, thank you for the question. And the first thing I would say is, and I'll try not to say this without crying, is thank you for saving my friend's life. Thank you. But also, I think that's a very important question. How do we not just, and this goes back to when I casually said, lend the megaphone as if I owned the megaphone. How do I decolonize my mind a little more to understand that I don't own the megaphone, and that I can give the megaphone, not lend it, or that someone else can have the megaphone because maybe it isn't mine at all. You know, it's just a megaphone that I lucked into through privilege and through the structures of the social order in which I live. And so I think that's a really important question. And I suspect I'm probably not the person to answer it, but I think for me, that's about amplifying Henry's voice directly. So sharing Henry's YouTube channel, sharing Henry's TikTok channel, sharing Henry's writing. I mean, Henry is a wonderful poet himself. And so, you know, that's about, and I try to do that, but I need to try to do it more.
Thanks, Mariama. So I think we're out of time. I just by way of wrap up, Ophelia Dahl, one of the co-founders of Partners in Health, who's here today, reminded me recently of a memo that Paul Farmer wrote to the team at Partners in Health and the whole Global Health Delivery Partnership in 2006, 2008, at another time of economic crisis. And it was not as deep and dire as now, but the memo was entitled Pessimism and Optimism in Economic Crises. And the basic theme of the memo was when everybody else is in retrenchment mode, when everybody else is pulling back, those of us who are invested in equity have to actually double down and do even more. And this is not a time to be settling for less. And it may mean we've been talking about some really uncomfortable partnerships that we would not have previously considered, but it may be time to consider some of those new things, some reform in the ways we've been doing this work, but certainly not to pull back. You want to add anything to that?
Amen. Thank you all.
Thank you, John and Carol, for that insightful and deeply human conversation. And may I add, I think it's more than a conversation. I think it's an invitation to rethink. And only John Green could make us laugh, reflect, and really rethink how our relationship with what moves us can evolve. So thank you. For those of us in the room, we invite you to grab lunch just outside this hall. And for those online, we'll be back right promptly at 2:25. We have a special message from Dr. Tedros Ghebreyesus, Director General of the WHO, when we return from lunch. So thank you so much.
it as a, I mean, the reaction must have generated around introducing the techniques. And I wish the academic institutions got really intense. All right, I'd love to hear that. In a similar way, they're feeling threatened now. That was more than your challenge. I hope we can reach it into the healthcare relationships, get honest, and be mind together. We can do a whole lot better. No question about that. If this precipitates that fix, that'd be a good thing. That's what they wrote you. Yeah. Very good to see you. Great to see you. Very so good to see you. We're going to be in touch. No. Yeah, I appreciate it. Nice to meet you. The dean's comments really applied. talk to him.
What should I do with my stuff? I assume you don't want it over there. And is there a restroom? Yes, it's right around the corner of
All right. I'll be sending you a signature here. Sorry, thank you so much.
Thanks a lot.
And find me if you need me.
All right, good to meet you.
Good to meet you.
Yeah.
leaving, a lot of people in high school to the East Coast for the first time. So there's a waiting list in order to get brought that has lived on. So now but half the faculty that I'm with now at UCSF, their kids go to the same schools. They all went to public schools, local. And that's a nice thing. It uses the system that you're in. Where did you live when you were in school? Global Valley, yeah. That's wonderful. Yeah, Global Valley is just terrific. I lived in the upper Cape, just up there from the tunnel of Global Valley. You walk up to Cass Ferry, I can't remember the street, that same water. But I think back on that time, it was a fun time for me. And everything is still possible in a way that, you know, modeling on civil rights movement. People in the UC system still hold that idea and carried it. And one of it was another. It's funny how it is. I graduated in 78. I thought it was a really strong message. You were in a class of 50% women. Yeah, because it was my class that made that start to happen, and it continued, I think. We wrapped up a lot of women, within 50 forever. Yeah. I had just gone co-ed the year I started, so it was bizarre. No one was back. And the women that were there were geniuses of the type that could always talk. So they were strict in the community. No, it's, yeah, it's funny. But there were a lot of really wonderful people who were there. There weren't a lot of technology. So I met her at UC years later. She was a minister in the Department of Cardiology at St. And basically ran, you know, how the UC society, she didn't stop working, so I had the luxury of having her not be a teacher.
Hello, hello. We're going to get back. For those of us here in the room, please take your seats. We're about to get started with our afternoon conversations. And for those of you joining us virtually, thank you again for being connected with us. We have, as I mentioned before lunch, a very nice surprise that Dr. Tedros agreed to send us a message today. So I would like to share this message with you with a pre-recorded video. So my colleagues here in tech will put it up. Thank you so much.
Dr. Louis Ivers, esteemed members of the Harvard Global Health community, dear colleagues and friends. For many, the COVID-19 pandemic seems like a distant memory, overtaken by conflict and geopolitical and economic upheaval. What has been forgotten is that it was a time of deep inequity when wealthy countries had more vaccines than they could use, while lower-income countries went without it. The WHO pandemic agreement that's now being negotiated by countries is designed to make the global response to future pandemics more coordinated and more equitable. At the same time, we face increased inequities due to the sudden withdrawal of the US funding from global health. Some other countries have also reduced development assistance to fund increased defense spending. This is causing severe disruptions to programs for HIV, TB, malaria, immunization, polio, and health and humanitarian emergencies. WHO is working fast to adapt to this impact, both on our own work and on the countries we serve who have been affected by cuts in bilateral assistance. While global priorities can change quickly, health threats don't. Just this year, we have had outbreaks of Ebola and Marburg virus disease, while avian influenza continues to evolve and measles is spreading quickly. Equity has been at the heart of WHO's mission and mandate since we were founded 77 years ago. The vision our founders had then remains our driving force today. The highest attainable standard of health, not as a luxury for some, but a fundamental right for all. I thank you.
We thank Dr. Tedros for these important reflections and a real call to action as we move forward in our conversations today. It is a pleasure to now introduce our last plenary session of the day, entitled The Science of Trust, Restoring Confidence in Science and Public Health. In an era where misinformation can spread rapidly and skepticism towards science and public health initiatives poses significant challenges, understanding the roots of trust becomes paramount. Our panelists today will delve into strategies on how to rebuild trust, fostering transparent communication, and reinforcing the critical role of science in safeguarding public health. Our distinguished panelists are Emily Smith, Assistant Professor of Emergency Medicine and Assistant Research Professor in Global Health at the Duke Global Health Institute. And I will ask my esteemed guests to please make your way to the podium. And Professor David Lazar, University Distinguished Professor of Political Science and Computer Sciences at Northeastern University, and co-director of the new Lab for Digital Humanities and Computational Sciences. Joining us virtually is Gitanji Gitaji, the Group Chief Executive Officer of Amref Health Africa. And finally, our moderator today is Matthew Baum, the Marvin Culp Professor of Global Communications and Professor of Public Policy at the Harvard Kennedy School. Anticipating an engaging dialogue, I yield the floor to Professor Baum to take it away. Thank you.
Thank you so much. We should have no trouble solving the problem of trust in science over the next 30 to 60 minutes, so we'll just start right in and fix the problem. Basically, the plan is for us to have a conversation for about a half hour, and then we'll open it up to you all for hopefully a broader conversation where we can pick up and extend some of these issues. So I want to start with a question for Professor Lazar. We seem to have arrived at a place of historically low public trust in science, scientists, and the scientific enterprise in general. And I'm wondering if you could say a little about how we got here, both in general terms, but also maybe more narrowly with respect to the role of misinformation and disinformation, as well as the related parallel problem of rising partisan polarization around trust in science almost across the board, and certainly in particular in the area of public health. I know it's a mouthful, but
I'll give my 10-word answer. Well, thank you, and thank you to the organizers for inviting me. Thank you to my fellow panelists. I think this is so very important. I do want to begin actually with just 1 minute digression, and then I'm going to dive into my answer, which is I've decided for every opening set of remarks when I'm in public to make a plea to leaders in universities, scientific institutions, medical institutions, to figure out how to more effectively work together. We are in a moment of existential crisis. I'll go into the clinical diagnosis in a moment, but I think that the only way we survive this is if we figure out effective ways of working together, pooling our resources, mobilizing a public movement, supporting our institutions. So with that, I have longer remarks than that, but I'm going to keep it short and get to answering Matt's question. I'm going to just go through a set of points. I should note that because I'm so PowerPoint dependent, I actually have slides that I've posted online that have some of the descriptive statistics. So if you go to tinyurl.com/sciencetrust, it will take you to slides with some of the descriptive statistics that I'm talking about. So I begin just with a set of remarks that are obvious but crucial, which is that trust in science is essential. I mean, just trust in institution is essential for society to work. Right? I took the elevator up here. I trusted that slender string holding the elevator wasn't going to snap and that I was going to plunge to my death. Many of you got in airplanes here. All that requires a degree of trust. And nowhere is trust more important than with respect to public health. When you, let's say, talk about vaccination and getting vaccinated requires trust. And for many of us, it's not something we even think about. We did a survey where we asked people, why did you get vaccinated or not? Well, for the people who did not get vaccinated, the central word, giant in the word graph, was trust, like just what they wrote down. It's because if you don't have trust, it's like air. If you can see the air, there's a problem, right? And if you think about trust, it suggests that there's a problem. So moving from that essential point, I'll also note that one of the figures we have there looks at data we collected at the state level, trust at each state, and then subsequent mortality rate after vaccination. There was an incredibly strong correlation. It was incredibly predictive of vaccination status a year after we asked people in the summer of 2020 whether they were vaccinated a year later. The interesting thing, and there are bits of good news to say, trust in science is actually quite high relative to other institutions. It did go down after COVID. It went up and then it went down. I have a plot there of trust in science over the last 50 years in the US, and I'll admit my parochial perspective here. I'm focusing on US, but what happens in the US doesn't just stay in the US, as we've seen. That actually trust in science has been pretty flatlined for the last 50 years. Some of this depends on the kind of measure, but for the standards of general social science survey, it's been essentially flatlined with a spike up during COVID and then a drop back to baseline after COVID. So that's actually very good news that that science is one of the most trusted institutions
in the US currently. But there are caveats to that. Well, first of all, there have been consistent demographic gaps in trust in science. For the entire 50 years, it's been quite steady in terms of the demographics that have been less trusting of science, which includes people who are less educated, African Americans, people from rural areas, women, the more religious, and people, lower income people. Those demographics have been just systematically less trusting of science. And part of what we'd argue is that a lot of that has had to do with structural gaps between those groups and science. And indeed, we did some experiments where we said, do you trust the advice from the scientist? And we varied the demographic attributes of the scientists, and it turns out that demographic similarity was predictive of trust, but especially for underrepresented groups. And then the final point, and this really gets to the current political moment around political polarization, is the one place that has been very unstable in terms of trust in science has been partisanship. And what's interesting is that the groups that many of the groups that were less trusting of science, especially in terms of education, have polarized in terms of politics. So people with higher educations have shifted towards the Democratic Party, less education towards the Republican Party, and that has was driving really since the aughts a partisan gap between Democrats and Republicans, where Democrats were more trusting of science than Republicans. Before that, Republicans were more trusting of science. And so that sort of switched in the aughts. And that little gap then became a chasm through COVID. And I think part of what happened was that gap created partisan opportunities for, on the Democratic side, saying follow the science, and on the Republican side, say don't trust public health, don't trust the science. And it was advantageous because it won the median activists in your party, right? In a period of political polarization, it becomes extremely important, more important to win the median partisan in your party than to win the median voter in the general electorate, and I can go more into that. But that has created basically an undercutting of trust in science among Republicans. It does create, and that has in part yielded the current moment. And I think, again, that there was a way in which COVID was very much an accelerant for that process, and that is, his life is path dependent. COVID came along at a very particular point of time. If it was 20 years ago, it would have happened, I think, unfolded very, very differently. But we are where we are, and I'm going to leave it there, and we can talk about the future, in a few minutes, I hope.
Okay. So let me pose a question to Dr. Gitahi. I'm looking at the screen where he's located. So let's narrow our focus a little bit and talk about the problem of health inequities. Could you talk with us a bit about the public health related lessons learned from Africa during the COVID pandemic in general, and in particular with respect to the role of misinformation in exacerbating the public health challenges in particular, as well as, if you would, measures being undertaken to combat the problem of misinformation?
Thank you very much, and thanks for having me even virtually, since I couldn't make it in person. Africa has a very diverse population, countries. We have 53, 54 countries, depending on which ones you're counting. There are some that are not, controversial, not recognized or recognized. But anyway, more than 50 countries exist in Africa. And they are not as united through the borders as those in Europe, for example. And therefore, you find that the dimensions of the response, misinformation response, also acceptance, were diverse across the continent. So there is no singular answer to that question in terms of Africa, but there are diverse responses country by country. I think the first thing I would like to say is that right off the pandemic, some countries were found with more experience of response to health threats than others. Uganda had dealt with several outbreaks of Ebola. DR Congo had done the same, and plus other outbreaks of Mpox that have been there since the 70s. Nigeria, Sierra Leone, Liberia had dealt with outbreaks. Others were not as experienced as those countries. And therefore, very early on, we started to see what happened based on this experience. Some countries actually pulled back on those experiences. And we saw, for example, that in some of these countries, community-based surveillance became the first thing they did. And obviously, because of the lesson that they had learned earlier, that community leadership in the response was the most important thing, because people trusted their neighbors. At community level, we have what we call community health workers in Africa. I'm sure they're also in other countries. But the ones that we have in Africa are not as professionalized as those you have in high-income countries. And therefore, they are basic, minimum, bare bones kind of information on health, but it's built not on huge levels of literacy and education, but it's built on these individuals who are selected by their own communities have been found through these responses to be critically important in the responses, in surveillance, and in contact tracing. And those countries had already learned that. So they brought forth community leadership, community level leadership in the response. Regionally, we saw, for example, that WHO Afro, which is the regional WHO arm, and Africa CDC started to come on very early. Now, what we found was that WHO, whereas it was giving good technical information, was affected by the lack of trust that the populations had on WHO itself from Geneva. And this lack of trust in WHO itself, which flew all the way down to the regional body, was related to early attacks and in misinformation and attacks on WHO, which also said WHO was captured by certain individuals, captured by industry, and therefore was seen to be advancing a position that was pro-industry, not pro-people. And therefore, the institution of Africa Centers for Disease Control, whereas much weaker, much more not as endowed as WHO, received a lot more trust because it was seen as an African organization. So ownership became a driver of empathy and authenticity. It was seen as it is ours, therefore we can trust it. And WHO, whereas it continued to work with countries, it really found that it could struggle. So organizations like ours, like AMREF South Africa, because we work in multiple countries, emerged to fill the gap of trust. And because we work at community level and with governments, we were seen as a trusted source because we are non-governmental, we are not multilateral, we are not governmental, we are not private sector. So civil society came in to fill this gap of trust. But amidst all these things, I think the key lessons we learned, which I would like to share, is that trust was more useful where it existed before it was needed. There were studies done by Africa CDC, surveys on, for example, acceptance to response, wearing of masks, social distancing. And what was seen is that the rate of acceptance of these public health measures were higher where people originally trusted their governments, even before the pandemic. Ethiopia, for example, had high levels of trust. And therefore, the government announcements and policy positions were more accepted and not questioned by the population. We saw the same with Rwanda because they trusted their governments highly. In areas where there were political division, there was a strong opposition that was fighting with governments. We saw less and less trust for governments, and we saw more and more attacks on the government policies and responses. So lesson number one was that trust was more useful where it existed before the pandemic. Therefore, trust in peacetime was very important in war. And this also related to the health system themselves, where people had tried to use the system before and they had not been served. There were high out-of-pocket expenses, there were no drugs in the hospitals. Before, in peacetime, people trusted the health system less during the response than countries where the health system was originally working. So here, saying that a good health system in peacetime is useful in war. The next thing is false narratives. These false narratives included being driven by key opinion leaders, like religious leaders, who had misinformation, and also community leaders who are not well informed. These were moving narratives like, for example, that vaccination was driving implantation of chips in people's skins for use by global forces. Talking about creation of infertility through vaccination. So all these conspiracy theories came to affect the response and also affect the vaccination rates. But as I conclude, it's to say that there are things that worked. Where we found things working was, number one, as I said, where trust existed before, but number two is where the responses were people-centered, where actually the policies asked What are people doing right now? Where are they? And therefore, you worked on the policies that were pro-people activities, not anti. We saw South Africa, the lockdowns became very controversial because they were anti the informal sector. People needed to go to work to earn because not everyone is formally employed. And therefore, where the policies were not aligned to people's lives, they were opposed, and there was actually uprisings. So human-centeredness, even in vaccine provision, was successful. And where we had a big challenge was where countries did not open up their health centers over the weekend. And therefore, people did not receive vaccination because over the week, because the health centers were not open during the weekends where they are free. They are open when they are busy working and earning a living, a daily wage. So we saw lower vaccination rates where governments insisted people go to facilities on Monday to Friday. So I think I would like to first close there. But these were the key lessons that we learned. But I think finally, I would like to just mention here that trust did not develop organically for institutions. It was actually something that people already had for those institutions based on the way they had treated people and they had worked with people before. Over.
Thank you so much. Okay, a question for Dr. Smith. I was wondering if you might talk with us a little bit about the interconnectedness of trust in science, misinformation, and public health, both domestically and globally.
Sure. Maybe I can begin by saying why I'm here in the first place. Because my day job is at Duke. I'm a global health epidemiologist, looking at the intersection of poverty and children's health, war and conflict. Many of the children that come to the clinics where I work come with advanced cancers. So I work with St. Jude, or advanced surgical diseases that just cannot be fixed anymore because they waited too long. The reasons that they got there too late, though, most of the time is because the families had to make a decision between care for one child or feeding the rest. And so my work is to try to make that decision obsolete. So that's a long way. That has nothing to do with trust yet. COVID hit. I was in Texas at the time. I started a Facebook page called Friendly Neighbor Epidemiologist because I can be a little too friendly, a little chatty. I'm sorry if I sit by you on an airplane. But neighbor because I love the story of the Good Samaritan. And most of us know this story. You know, a man is hurt on the side of the road. Two people walk by, and those two people were religious leaders of the day that denoted power and privilege. But a Samaritan man stops and he takes care of the man. Not only that, he takes him to a place to recover, and then he pays for all of it. And I've loved that story. To me, that is what epidemiology is the science of the Good Samaritan. That's why my book is named The Science of the Good Samaritan. So that's a long way to say I named Friendly Neighbor because a lot of us epidemiologists knew something like what we were seeing in Wuhan was going to make us neighbor each other well, or required that, or the lack thereof, there would be repercussions. My global health equity work that I'd already done too, I work in Somaliland, in Burundi, and I knew if something like COVID hit there's no PPE. And when it actually hit, there was no PPE. So indeed, the disparities showed up. So I started the Friendly Neighbor Epidemiologist page thinking it was going to be for a couple of weeks. Help people understand, flatten the curve, whatever. And we all know that didn't happen. I was in Texas. My husband is a pastor. We were at a very large evangelical church. So everything you saw on the news about Texas or what you don't want to see, I'm trying to be politically correct here, but everything you saw on certain news channels was my neighborhood in my church. And so when COVID became weirdly political, we all saw this. When George Floyd was murdered, when January 6th happened, I kept writing about it. This is a public health issue. This is an equity issue. This is a COVID issue, sure, but these are systemic and structural determinants that many of the people that I was writing to had never seen before. I wasn't noticing that it was going viral multiple times for good and bad ways. It would end up hitting 10 million people, and I continue to be in 160 countries with this platform. I've kept it up. But it was such an interesting experiment on developing trust with socially, on social media with a group of people Mainly, I mean, I got in the door a lot because I was a pastor's wife. It's fine. I got in a lot because I was an epidemiologist. And then when you infused equity, and I was telling people about Somaliland for the first time and they'd never heard about that country, you know, there's an opportunity there to do some education. Now, we would move, you know, leave jobs for lots of reasons. You can probably imagine why when it's untenable to do what I'm doing and where we were at the time, which brings me to Duke. But this issue of trust in science, I mean, it's certainly deep, but it is centered within the communities of where trust is lacking. And that to have trusted messengers there, you know, to be able to speak into whatever disadvantaged group or advantaged group. For mine, I mean, my own people were the ones that were the most hesitant against wearing a mask. And so for them to hear somebody say from the pulpit, actually you can use scripture to say this is loving your neighbors, is putting on a mask and getting a vaccine. So that's how I snuck into this forum, was through a roundabout way of being now a science communicator who's still doing global work.
Okay, great. Let me follow up with each of you and push a little bit on the issue of misinformation. So starting with David, in the story you told us at the outset, where does misinformation fit into this? As a cause, as an effect, as a peripheral player, as a main focal player? How would you characterize that problem?
I'd probably say as cause and effect. You know, we could see, for example, that in the work that in the COVID States project, and this is Matt and I and a team of folks. It's a large survey we were conducting, still conducting actually, although it's rebranded CHIP 50, that we found, you know, that you could look at people who, again, early in the pandemic said they were trusting or distrusting, and it was highly predictive of future belief in misinformation. And it was related to where they got information, but it was also related to what information they were receptive to. So there's one way in which trust then affects where you get information and what you're going to receive. So in that sense, trust is causally antecedent to belief in misinformation. That said, you know, the misinformation itself, one of the things that one of the targets of misinformation is to undermine trust. And so that's where, and we have other research predates this, but we're looking at how exposure to misinformation was in turn predictive of lower trust in certain institutions. And this was work with a collaborator, Katja Agnunova, and a number of others, well before the pandemic. But we were looking at, again, repeat respondents, exposure to misinformation, and how that was, again, predictive of a reduction in trust. So I think that there is sort of a cycle here, and some things are also based on life experience. And so another thing we could see is, sometimes the institutions we would like to trust are not trustworthy, right? I mean, if we think of the opioid crisis, a large chunk of that came through trusted institutions. It came through big pharma. It came through PCPs. And we could see, again, in our survey, a huge fraction of the country is being affected by the opioid crisis. We estimated, you know, in terms of people who said, let's say it's in their immediate network, was roughly 1 in 5 people. And those people were less trusting. They were also less likely to be vaccinated. And you know what? They had some basis to be distrusting of the institutions, to be distrusting of pharmaceuticals, to be distrusting of doctors. And so this is, again, it's not just about misinformation causing distrust and so on. There are life experiences. There are obviously the experiences of particular groups, but there are also experiences of particular people and people in their networks. And we in the U.S. certainly we have had some reasons in the last generation that to say our trusted institutions really maybe shouldn't be so trusted at all. And so there's like that's sort of part of the whole equation, I think.
Okay, great, thank you. Dr. Gitahi. In our conversation a while back where we were talking about what we would focus on in this panel, you recounted a personal story regarding your experience with misinformation, in particular AI-related misinformation. And I was wondering if you'd mind sharing your experience with us and what lessons you drew from it.
Yeah, thank you very much. What I've found through all these journeys and my personal journey, which I'll share, is that human beings are by nature want the easy way out. So if you have a long-term disease, a chronic disease like diabetes and hypertension, whereas science tells you this is chronic, you'll take this medicine for life, misinformation will come and tell you, I can give you something that solves your problem in 2 weeks. It's the same with weight management. It's the same with all these challenges. It was the same with COVID vaccination, where people feared the injection and they were not sure because people said it will be painful, there will be fever. And then they were told, no, you don't need vaccination, just take lemon water. It was easier to take lemon water than to actually get. So the ease of misinformation challenged science, because science is factual and science is difficult in terms of the solutions it gives. They are not instantaneous. So what I found myself is, because of the trust that I built during COVID, because I spoke a lot about vaccine injustice, I was on TV a lot, and people listened to me because I said earlier that we tended to close the gap, the trust gap that was there between government and private sector. So people trusted me. Now, people have taken my image of videos I'm speaking, like I'm speaking now, and then used artificial intelligence to alter the audio. And they will have me speaking about, for example, just as I'm speaking now, they'll alter the video and the audio, and I'll be saying that I've discovered a new medicine for hypertension, and if you buy it, you will actually be cured in 3 weeks. And people are buying $100 a month, such medication. Another video followed on diabetes, another one followed on erectile dysfunction. So they pick topics that are difficult for our people, for individuals, where science gives long-term solutions, and they give short-term solutions through AI change. So this threat of misinformation through AI is something that's going to make our work even more difficult, and that's going to complicate the trust in public health institutions even further. And therefore, there is actually a need for urgent, innovative resolution of AI use in ensuring that in saving people's lives and livelihoods as well.
Thank you very much. Okay, Dr. Smith, your turn. So you, as a self-described science communicator, what role has misinformation played in the efforts that you've been focused on with your work? How much of your time is devoted to combating the problem of misinformation? And if I can generalize from that and give you back a question that you suggested to me some time ago, how can you effectively talk about public health without losing your soul in the present environment?
Well, I asked that question because I kind of lost my soul. I mean, during COVID, it was so misinformation. It still is, but it was so daily and upfront. And so I wrote, daily post 500 times in a row, pretty much of during that time. And a lot of it was talking about some of the science coming out, especially when vaccines, helping people understand the safety and efficacy of it. But most of it was combating misinformation. You might have heard this. Let me actually tell you the truth. I say that question of how do you do that without losing your soul? Because most of us, I'm sure everybody else in this room feels the same way, just got burned out by always being on the defense like that with miscommunication. So now that we're back in the game, essentially, we all had to jump back in with the new administration. My approach to misinformation is a little different, where I'm still combating it, but I'm choosing carefully. Because what I've learned, if we think about measles right now, my hometown and where I went to undergrad is the hotspot of measles in New Mexico, and so Midland, Lubbock, Lovington, Hobbs. I mean, those are my family essentially. I think one of the tactics of the new, maybe the new administration or maybe the Children's Health Defense or some of these that are the anti-vax, they're incredibly well coordinated and a lot of money. I think one of their tactics is to throw out a lot of misinformation at us and see if we'll just try to play whack-a-mole with it, and then we all get tired. So at least that's what I'm doing now, is I'm choosing carefully what to talk about. With measles, you bet I talked about vitamin A. And was it cod liver oil or one of those that, like, don't do it for your kids, guys. They will get very sick. But there are some misinformation that I'm just choosing not to talk about. At the same time, I'm talking about the truth. And if you can talk about the truth in a bigger umbrella about overall vaccine safety, that covers a lot of misinformation without you having to play whack-a-mole. So wisdom, yeah.
Yeah, I was tempted to quip, at least it's not bleach.
Oh, I know. Goodness gracious. Yes, sure.
The last question I want to pose to each of you, which you actually just sort of touched on, so maybe I'll focus more on our other two panelists, is where do we go from here? Any insights you can offer as to how we might go about restoring some of the lost trust in science and scientists?
Well, maybe I'll start. I don't have the answer. In part because
I promised within 30 minutes.
30 minutes. Well, we have 3 minutes. So in 3 minutes, again, the funny thing is, I don't think we've seen a plummeting trust in science. I do think we've seen, in some sense, it's the interplay in the U.S. The interplay between trust and partisanship, and I do think that's a huge problem because. It's a huge problem because it's a huge problem in the moment, but it also suggests that in the best case for the next generation, we'll go through feast and famine in terms of support for public health and science and medicine and so on. And that's not how to build institutions. You can't bring in grad students for 4 years and then cut off all funding for postdocs and et cetera, et cetera. And you can't fire everyone and then hire a bunch of people that those people move on. I think, I do think that, again, the good news is that there is actually a lot of latent goodwill towards science, even with a partisan gap. I think that we in the U.S., need to figure out, again, how to use that to mobilize support, because there is an interest everywhere. And I think that part of the question is, how do you build those networks? How do you build those bridges? And then the longer haul, again, is how do we build bridges? And we talk about, diversity, equity, inclusion, and so on. These are the forbidden words right now. But they're the questions of, like, how do we build better bridges and more bridges? Because I also think that that at times we neglected socioeconomic gaps. At times we neglected outreach to rural areas, and that we need to do better. Which, unfortunately, I think in the short run we're going to do worse, a lot worse. But I think we need to figure out, how to build those bridges in adverse conditions. So, that's the best I got.
Okay, Dr. Gaddafi, your turn.
Yeah, I would like to say that the most important lesson for me is that science institutions, public health institutions, must focus on being community facing so that they can build trust every day. Their innovations, their policies. We talked about, for example, the innovations of vaccines. And we said, if the people who are working on vaccines do not consider that people are afraid of pain, that people do not want to go to the hospital to get their vaccine, they prefer to have it at the local pharmacy, that actually the whole community's social behavior must be part of science, meaning that then the people trust us, and therefore when they need us, they'll have built the trust. So we must build empathy, logic, and authenticity in our work as science practitioners, even when it's not needed, because then that means that we connect with communities de novo, even before we start the research. And I think even in research, we are told that we have to talk to communities way before, but we ignore these things because we are too focused on the hard science. The next thing is about public health institutions must remember that their core audiences are the people on the streets. Therefore, simplicity, connectedness, and people-centeredness are critical. That we must communicate simply. We must communicate in people's lingo. And that is when people then connect with us and say, I think I can believe you because you sound like me. And that is authenticity. You sound like me. But I think scientists and many of us are actually snobbish because we talk about just the facts, the policies, and believe them or not. So it is our turn now to think, how do we actually become community connected, simple connected, and people-centered, and communicate with empathy and authenticity so that the trust is built before it's needed.
Thank you. And I know I said I would give you a break, but I decided not to. So I'll give you the last word, Dr. Smith, and put the same question to you anyway, if you want to elaborate a little further on it even.
I think of it more from a, how do we do this on a normal Tuesday? Again, while not losing our soul. And through the lens of equity and of neighboring. And, you know, there's so much talk right now of we just need to meet in the middle, or we need to just come together. And this is bipartisan, I mean, just however you want to slice that. Historically, though, that middle has been biased and not the actual middle. So there's so much work to happen to bring the people who haven't had a microphone, like John Green said earlier. I loved that, that discussion, to let them have the microphone a whole lot more than those that have actually held it in terms of some power and privilege. So I think moving forward, if we can center, that's why I'm such a big advocate for neighboring. If we can center neighboring, to me, it helps diffuse tension in the room, even amongst differences, because neighboring means I'm going to neighbor you and you're going to neighbor me. You know, it's a walking with people instead of over in a power dynamic. So I'm hoping we can have a posture of neighboring with one another. That does not mean that everybody gets a seat at the table and can say what they want. That does mean that you come with the, you know, the focal point of equity in the middle.
Okay, thank you very much. At this point, I'd like to invite the audience to ask questions. If I could ask you to please identify yourself before your question. And we're going to be going back and forth between the folks in the room and the virtual audience as questions arise, but floor is open.
I'm Megan Murray. I'm an infectious disease epidemiologist. Use a microphone.
They're going to bring you a mic.
Thank you. I just said I'm Megan Murray. I'm a professor in global health and an infectious disease epidemiologist. One of the things that those of us who are involved with COVID have been doing lately is sort of postmortems on what we did wrong. And one of the things that has come up fairly often is that we often, especially early on, overstated what we knew about the science to the point where we lost trust of people who, when we turned around and said, oh, actually, that's not right. You know, we're going to change our minds on that. There's a number of books out on this, and I really think that was part of a sort of self-inflicted wound that we, you know, we were more confident than we needed to be, or that the evidence supported. How do you think that contributed to the sense of lack of trust? And if so, how do we fix that now?
So whoever would like to field this?
I'll give an initial answer. My instinct is to say yes. I mean, certainly undermine my trust, right? I mean, to an extent. I mean, and I'm generally trusting of science, but there's definitely things as someone who knows some things and doesn't know other things, and I'm trying to figure out, figure things out in the beginning, and leaving my mail sitting in the hallway for weeks and that kind of thing. It definitely, there were a whole list of things which really, I'm probably better informed than most, but I definitely felt like, whoa, I remember, there are a whole bunch, there's a long list of statements. And so I do think, on the one hand, that some of those things had to
undermine trust, and that there was sort of overstatement of certainty, and there was a lot of the messiness of science, but then trying to somehow say, well, we're 51-49 sure about this, but if we just sort of say, we're a little sure about this, then no one's going to listen to us. It was a lot of it was understandable, but I agree with your instinct. I have to say, it is harder to, it's harder to, we don't get to run RCTs on like public communication. I mean, there are, I've run my survey experiments. But
we do.
Yes, we do, but we really don't, except for when I write the paper and say, yes, this is just like the real world. It really, it really isn't. But my instinct is, so I'm not asserting this with scientific certainty, to be clear, which is sort of ironic in the context. But it certainly felt like that to me. So,
Dr. Smith, Dr. Utahi.
I think it contributed a little bit. I don't think it was the main factor for trust. Also, maybe it's people don't understand the scientific method as well as we all needed to remember that this is an evolving situation. I think it was more of the distrust that was already happening in the communities and it just being amplified. I also think politics just wreaked havoc. And I feel like politics was the bellwether for, the pivot point to this rather than what scientists did wrong in communication, or if we would have been a little bit more hedged with our bets. Yeah. I just don't think that was the biggest contributor.
And I'll add, we sort of came back to baseline, but we didn't end up in a worse place, or not, maybe a little bit, but not clearly. And so, again, but again, the partisan split, and I do think that fits with exactly your story, which is the interpretation of all of this messiness. There are two different worlds in terms of how to interpret what happened over the last 5 years. So,
Dr. Utahi, would you like to weigh in?
Yeah, I could just mention that, it's a really profound point, because many of us will remember that WHO was really punished by its attackers on their position on masks, their use, their efficacy earlier on. And that became a running issue that WHO did not know what they were doing. So I think the accuracy of information, certainty versus clarity, I think it's important in science to have clarity, but not, when there's no certainty, we should say there's no certainty. And I think that was one area that WHO was attacked for the use, for being certain about the, not using masks and then changing their position, whereas people saw that as dishonesty, whereas it was actually just scientific use of scientific facts. So there is some element there about whether, as an institution, how certain should you be about science that's not certain, and probably having clarity about what you know, what you don't know is probably a much better approach. But it's difficult. It's a very difficult question, because you never know, because things evolve as well, and science evolves and facts evolve.
If I could actually break the rules of being just a moderator with no opinions, and and follow up on Dr. Utahi's point, because we actually have a new case this year at the Kennedy School that all of our first-year master's students are taking, that's focusing on the question of, the early decision to say that masks weren't needed through the lens of noble lie theory. So the idea that basically, and was it because of scientific uncertainty, or was it because first responders had urgent need of the supply, that we had inadequate supplies and that needed to be reserved for first responders, some combination of both? Turns out it's a really hard question when you actually push on it. What was the right thing to do? I think there's little doubt that that whole situation played an outsized role in decline in trust in science and COVID. So I completely agree, Dr. Utahi. But what would have been the right way to do it? Probably full disclosure. Although if there had been full disclosure, lots of people would have hoarded masks, and it would have thwarted the goal. I'm fairly confident in suggesting. Okay, other questions? Yes, ma'am.
I'm Shoshana. I'm an undergraduate student. My question was about was kind of touched on before about how science inherently changes and how I feel like that is a big part of why science communication and building trust is so hard, because trying to communicate that when we get new facts, we're going to revise models and revise guidance is something that makes it sometimes feel like we're communicating not the truth because it changes so rapidly. And if you have any input or thoughts on how to more effectively communicate the fact that that is just how science works and the fact that the facts don't always stay the same.
I can start us off, and can I just say you did a great job of saying that. You should be a science communicator. I think exactly what you just did of things evolve. I mean, you said it so conversational, and people, your tone was you had nothing to prove. You were just asking a question. I think the way that you approach that is the way that we can build some trust with people, and just to say, gosh, science changes. And I think also when they know a scientist, like a lot of people that distrust vaccines knew me personally as a scientist. So I got a lot of, Emily, you would not lie about this, right? No, I wouldn't. Okay, maybe I'll go get the vaccine then. I think there's a way to develop science communication that way too, of me saying the data is still coming in, but early indications are. There are some code words and stuff, but you did a great job if you ever want to do that.
So could I push on you on just one thing you just said? You said, Emily, would you lie about that? And you said, no, I wouldn't. And why did they believe you?
Oh, because they know me. They know me in person. I mean, I'm not a person who's gonna lie. Yes.
Okay, so in other words, they trusted the messenger.
They trusted the messenger. Yeah. That's why it's incredibly important to have trusted messengers. It's not just trusted messengers. I mean, this is getting off topic, but when Dr. Fauci is up there or Dr. Collins and they are saying something, we don't have to know them to trust. I trust the science because I've got a history of trusting the science too. So I don't want to put the onus only on trusted messengers. I think it's a both and. It's the trusted messengers plus the leaders that we see talking.
Dr. Gitahi, Professor Elizabeth?
Yeah. This is, again, it's a difficult one because we had these challenges. We were asked by people when we appeared on TV, people said, are these vaccines safe for pregnant women? Then you could say, no, they're not approved. Or yes, it's approved. But when people said, actually the vaccines are causing increased menorrhagia or more bleeding, or they are interrupting people's menses, you had no data that was there, what do? And you want people to take vaccination. Do you say, yes, I think they are? Or do you say, we don't know? Or do you say they are not? So it's difficult. And at the end of the day, it's also about the intention of the communication. If the intention of the communication is information only, then you give the information that you have. And I think this is where the challenge came in, even with the mask thing. But when the intention of the information is to actually influence behavior, it becomes more complicated because then you have a bias towards the behavior you want. This is why it's so difficult to do science communication, because you want people to get vaccinated. So when they came and said, are you sure they are not interfering with my menses? You want the person to get vaccinated. So you're more likely to say, I doubt they are the ones causing the challenge, therefore I think you should get vaccinated, versus maybe it's so maybe don't vaccinate and wait. So I think the intention of the communication is in the middle of this very big question, and I don't think it's something that you can eliminate, but I think it's just to be, if you, as was said earlier, if you're authentic and empathetic and people believe you're speaking because you have an interest in them and that they can actually trust you to be like them, then I think that you'll have a much better chance at success in your communication than if you're just an institution that is where people don't connect and there's no connectedness. That's what I would say. But it's a complex question, again, just like the earlier one.
And I just say, yeah, that's a central question, and it's a tough one. And I think that intention issue is really central because you know, first of all, you always have to simplify information. It's like, well, you know, I did a literature review on this, and you know, it's a little of this, a little of that, and of course, it gets to the research design and RCTs, but RCTs have their own shortcomings and blah blah blah. That's bad science communication, right? And so you know, it boils down to get vaccinated, right? But like obviously that's a gross simplification. And I do think there's an interesting short run, long run trade-off also in communication, which is in the short run, you just want, say, the person to get vaccinated, say. But in the longer run, you want that trust in institutions. And if you sort of oversimplify it in problematic ways and that sort of surfaces, you lose trust in the long run. And that may be an essential tension. And this relates also to the masking thing, which was, well, you know, in the short run, it's a noble lie, and we save masks for first responders. In the long run, we lose trust. And, you know, and that's going to have lots of downstream negative consequences. The other thing I would note is I wish we would change, at least maybe this has changed and I've missed it, but I wish we would change how we teach science in K through 12. Because you know, everybody, you know, who goes to educate, you know, everybody gets trained in science in some fashion. Not everybody gets trained in political science, right? But like everyone takes years of science, but it's often presented as a sort of a fixed set of facts. It's not really presented as a scientific method of like, this is what we thought. We thought crazy things 100 years ago, right? But you know, 100 years ago, they weren't crazy, right? And we learned and we did better science, and the science itself, the method changes because we, you know, there's a recursive nature to science, which isn't just about finding facts about the world, but finding out about how we find out about facts about the world. And it would be great to like teach things we were wrong about, and how we discovered we were right. And that would be great if that was just integrated in K through 12 education, because there's a way in which that if people change their mindset about like what science is, otherwise then you're just setting them up for disappointment. You're like, oh, you know, don't we just know this and they're just fooling me? It's like, no, we didn't really know. We thought we had a informed inkling, right? Like, but like that doesn't, you know, that's not great either when you're trying to persuade people. But like I said, there is a sort of complexity in some of this short run, long run issue, and then the other issue is really how do you get people to think about science. And people have a lot of years of science training, but it's not necessarily the way, honestly, that they should be, you know, that they should be trained in K through 12. And that sets us up all for kind of disappointment when we don't meet that perfect standard of certainty.
I think you just had a great idea for a 8th or 9th grade textbook.
Yeah, yeah. Well, my spare time.
Yeah, well, you know, you've got nothing else going on.
Could I add a comment? Could I add a comment, Michael?
You had a comment?
Oh, I'm sorry, I didn't see it. Sorry, apologies.
Hi, I'm Steve Schwartz. I'm with the Weiss Medical Foundation. Just a quick question. Based upon what we see happening with measles in the United States, can you relate that to the past few minutes of discussion that you folks have had?
You would like to field this one? Nobody wants to go. Dr. Gaha, you want to take the first one?
Comment first, and then.
No, I would rather not take this one because the measles vaccination in Africa is actually very straightforward, and we don't have any controversies. It's almost universal.
Oh man!
Used to be here too. Who knew?
Yeah.
No, I would rather not take this. Here it's universal. You know, we have 89% measles vaccination penetration in multiple countries in Africa. So that's actually would rather leave that to those people who measles politics.
Would any of those who are actually suffering from this problem like to comment on it?
I mean, I could talk about it. I had mentioned before about the misinformation section of it, but what I'm seeing, you know, sometimes we have vaccine that are, I mean, there's no getting to them. They are not going to take the vaccine. You have extremely hesitant. But then you've got this new group that are more vaccine questioning. So when I think of, you know, some of my friends in Texas or New Mexico, they are not blatantly anti-vax at all. But the past couple of years, especially during COVID, a lot of their cohorts, they started having babies and they started asking each other, should we get this or not? For the first time, I never remembered asking that question with my kids. I just did it. And so those questions started like a little sneak attack into those communities. And then when measles happened, it's a whole new Wild West, literally quite out there, of it's not the vaccine hesitant, it's the questioning ones now, of how do you convince them to get it when all of their peers are kind of banding together and saying, well, I'm probably not going to get it until they're 4, 5, or 6. I mean, that's an uphill battle. I actually don't know how to combat that, as well as, you know, most of the blatant vaccine hesitancy. But it's also, if you look at well, this is probably not on certain news, but if you look on some stations, the Children's Health Defense, I know I've named them already, but that's RFK Jr.'s you know, shop. It's incredibly well organized. They are there in West Texas, in New Mexico right now. And if you look at what is coming out from that group in terms of scientific publications against the measles vaccine, they are organized. Because the BMC Peds just published something, then they hit the news with that, and so there's a game plan. So it's different than COVID. COVID, we were fighting whack-a-mole with misinformation. This time, it is a big behemoth of, I don't even know what to call it, that is, you know, risen up. I mean, they've been there the whole time, but that is what we're up against now with measles.
The only thing I'd add to that is there's sort of an epidemiology of distrust that goes along with the epidemiology of disease. And so one thing is to state the obvious that there is sort of a clustering of distrust, which then creates a clustering of where disease can spread. And so that creates sort of pockets of vulnerability, of deep vulnerability in our communities for disease spread. But the other element is I mean, it's interesting you're talking about, like, also with respect to children and so on, that we could see in our data, like that in particular, for example, that women in their 20s and 30s were actually systematically more hesitant about vaccination for themselves. But I think part of that may have had to do with around worries around pregnancy and so on. But that it seemed like there was that there were certain avenues for social influence, in particular around social media, that were very targeted to those populations. But we could really see how that stood out as compared to, it wasn't women who were older, it wasn't men. There was a lot more hesitation on vaccination among women, again, just of that age. And so, but like it also related then to things like use of Facebook and so on, where there are groups where if you're looking for information about vaccines, that's where the gravitational force will be. And so we found evidence of that also around in terms of media use and so on, in terms of vaccine resistance and hesitance. So,
a question from the online audience?
Yeah, we have a few. I'll start with, in the new public space of social media, what really constitutes authority and trust? And what can social media platforms do to highlight science communication and convey accurate health info from the side of the media sources?
Well, I could jump into that a little bit, but I think that, and it's an interesting moment to ask that question. You know, I think one thing that social media can do is, identify, credible sources of information. When you're searching for information, be more likely to surface those. Which is a little, I mean, there are different kinds of social media and so on. And so let's say if we think of Google and you're searching for health information, is Google taking you, to health authorities, real medical journals, and so on. And the same thing goes with YouTube. And indeed, that there are a set of principles that YouTube and Google have signed onto in that regard. And so there are ways of surfacing quality content that I think that some companies have supported. It's tougher when you're dealing with it's one thing when you're searching for information, and it's trickier when you're dealing with interpersonal communication, right? So would you say that that email should, if you get something from a relative as saying something that is anti-vaccine, would you say, oh, Gmail should just, send your aunt's email into spam? And I'd say, no. I mean, that would be deeply troubling. And so there are these really, it's not an easy issue. I mean, I think some elements are like clear and other elements are really hard to figure out. And so, but I do think the other thing I'd say is it's actually really important for us to see what the platforms are doing in various ways. And I'd note that it's harder than ever to see what they're doing because the data around what big tech platforms are doing has retreated, and our visibility into what big platforms are doing is far less now than it was just a couple of years ago. And so that would be the other. It's not entirely responsive, but it's sort of like how do we shed light on what they are doing, because I think that's also important, and that's harder than ever.
So I just want to say that I have one or two relatives, if their email was directed directly to spam, I'm not so sure I would feel badly about that, but...
There's settings. You can actually do that.
No, I know. Would you like to comment?
Sure. I will say now is very different than COVID, to answer this one, during the COVID time, because Facebook is now censoring all of my stuff. And if people want to share the Substack or blog, it's automatically you can't even post it. It's not even they have that blanket censor now. So it is a different time of sharing. I mean, social media is lovely when it is indeed social, when it's a social good. And maybe in its inception, it was like that. You get to connect with buddies you haven't seen forever and family members and show pictures. It is now turned, though, to not be that at all. Some of the platforms, and I mean Facebook, Twitter for sure. I just got off most of social media completely, which I would advocate. If you're thinking about it, then just do it. You'll be happier. But TikTok is, there are some that are just going to be harder and harder to know what they're doing because things are ever evolving, always evolving. Security is also another issue for those of you who want to do science communication. We've received, like many science communicators, lots of threats, including at my house, against my children. And so there has to be a level of accountability for that, and that is not on the platform because I have tried multiple times. And so just to keep that in mind, it's a very different social media than what it was several years ago.
Dr. Gitaki?
Yeah. Two things I want to say. Maybe a quick reflection on the earlier conversation of communication, to also mention that communication comes with accountability and responsibility. I had an incident where, somebody brought someone who has clotting disorders. And I knew that if they don't get vaccinated, they are at risk of COVID and death. But if they get vaccinated, there's no real science as to whether the vaccines are going to affect, to make the clotting disorder a risk to their life. So I think even as we communicate, we must remember that we bear great responsibility, because you could actually communicate to someone and they take the action you recommend, and then they end up in harm. And when they end up in harm, it may be coincidental or not necessarily a consequence of your recommendation. And these are always at the back of our minds when we are advising people that there is accountability, there is responsibility, and life is complicated, and they could end up with harm and then end up saying it's because of the advice you gave them. So that's always at the back of my mind. On this issue of misinformation and social media, I may have my own views about Elon Musk, but if there's one thing I'm very happy with X on, is community notes. Actually, they raise AI that looks at information, and I wish that could be used on every post to say, this post, though it says this, science says the following, or WHO says this, and provides you with information for you to weigh your decision based on what has been posted. In my experience on the AI videos, AI altered audio videos that have been made of myself, I wish that Facebook had a way of using artificial intelligence to bookmark or to stamp fake videos where they actually check or say this may be AI altered, or this may be this and that. I think that would be hugely useful and a worthwhile investment for those investing in social media. Thanks.
Thank you. Should we take one more from the online audience?
Sure. And then this one kind of is a little broader on science communication in the sense that science is not really only about facts. It's also involves ethical and political choices in the context of everything. So how can science communicators also engage people in those dialogues in a multidisciplinary sense?
Everybody says after you, nobody will speak. So,
I'm happy to.
Okay, please.
I'm friendly, right? Friendly neighbor. I'm always happy to chat in. I think. Remind me of the question again.
So multidisciplinary science communication to those regarding like ethics, political choices, and much more.
Yeah, I mean, for those of us who are here, we are probably geared intrinsically because of the public good and public health and global health and equity. And so when COVID hits, we automatically see it as a political issue as well as an equity one. My work right now with St. Jude, and you heard a little bit about that today, where the disparities between children dying in low-income countries versus high-income is one of the starkest that we have in global health right now. That's a policy issue. That's a political issue. That's a colonial issue. I mean, you can bring, I think as a science communicator, you can bring all of that in. And if you can do it through a story, in my book, the chapter that continues to get the most emails is the one I wrote about Dr. Khan, who passed away during Ebola. He did not get the Z-map, but an American doctor who got it in a neighboring country during the 2 weeks after him did get it. Dr. Khan died, the American doctor did not. That is a structural violence, it's a political, it's a public health, it's an ethical issue. So if you can do it through storytelling and bring that out, then people, you can hook people a little bit more. But I say bring it in. If you can't help it, then bring it in, because everything is tuberculosis, right? Like we heard today. And so bring that in with the science communication.
If that's to me, so I would say that the first thing that scientists need to realize is that not everyone is a communicator. The fact that you can crack the DNA code or create some fantastic innovation doesn't mean that you're a communicator. We have different skills, we have different gifts, we have different talents. I think finding those people who are able to connect with your audience, because communication is also about who you're talking to. If you're talking to a group of health workers, then it is okay to use a different approach than if you're talking to the general public. So I think recognizing those and then identifying who the right communicators are for the different audiences is probably the best approach, so that there's no one size fits all, but it's actually a diversified approach depending on the message, the audience, and what is the intended behavior. Then you may need to find different people or different ways of communicating, is what I would say, if I got the question right.
I guess I think it's a fascinating question, and it's interesting because some sciences and areas of knowledge endeavor have normative commitments and others do not, right? I mean, astronomy does not, I think, have deep normative commitments in the same sense that public health does, right? Public health isn't just like, we're figuring out how people die, I mean, it's like, how do we prevent people from dying, and what are the kinds of interventions? Like, how do you prevent mortality and suffering, right? That's it's a pretty basic normative goal, but is a normative goal in a way that's not the case with astronomy. But I think it's, again, I'll go back to K through 12, but it would be great to think, to get people to think more broadly about what science is, and that science isn't just about like creating a machine to generate facts. It is sometimes facts to change the world. There's a purpose of facts, and science communication is in part how do you inform societal practices in ways that will make the world a better place, fewer people dying, fewer people suffering, and so on. And I think that's it would be lovely if we integrated that better into science education more generally. So.
Okay, so this clock is befuddling me because it keeps resetting itself every time I think we're out of time. But looking at my actual watch, I think we probably don't have time for any more questions and need to, unfortunately, bring this to a close. So please join me in thanking our panelists for what was really a fascinating conversation. Thank you so much.
Thank you very much. Matthew, Emily, David, and Dr. Gitanji, especially you, they're joining us at a late time. So thank you so much. You really reminded us of the importance of going past data, building connections, and being transparent, but also leaving us with a message of meeting each other at the middle in these complex times. So thank you again. And now we're ready for the last couple of pieces of our event. Thank you. It is my honor to introduce Andrea Baccarelli, Dean of the Faculty of the Harvard T.H. Chan School of Public Health. Dr. Baccarelli previously served as the Leon Hess Professor and Chair of the Department of Environmental Health Sciences at Columbia Mailman School of Public Health. He also served as director of the NIH Center for Environmental Health and Justice in Northern Manhattan, and as president of the International Society of Environmental Epidemiology. Dr. Baccarelli also previously worked at the Harvard Chan School of Public Health as an associate professor from 2010 through 2016. And now we're very happy that he's back as dean of the school. He's also a distinguished scientist and investigating molecular mechanisms by which a wide array of environmental exposures causes human disease. So thank you, Dr. Baccarelli, for being with us, and please take the podium. Thank you.
Thank you so much. Thank you so much to the team, Louise, everyone, for organizing this fantastic symposium. One of the disadvantages of not being anymore a full-time scholar, but also being a dean, is that you get invited to these amazing events, and you can stay only for a small part of it. But it's really good to be here this time, and what a panel, by the way. Thank you so much for this amazing panel on communication. And at today's symposium, you have wrestled with so many important issues on how do you strengthen health systems globally and health security against a backdrop of a world that seems to be moving in every direction except the ones we would like to see them moving to. How do you engage with the changes in federal policy that seems to diminish the voice of America in global health? And how do you combat misinformation and improve information around the health issue and global health? And I don't have to explain to this room that the challenges are really enormous. It's really a time of incredible challenges, and this is why we have people as amazing as you being together today to create solutions. And it's really interesting that this comes at a time for all of us that where we are creating new ideas and new opportunities. Especially this symposium has generated excellent conversation and true problem solving, both in this room here and online. So I don't know about this year, but I understand this symposium is incredibly popular with hundreds of people connecting from all over the world. I understand last year you had 800 people from 90 countries. And it's really a testament of the vitality and the role of the Harvard Global Health Institute plays in the world. Your mission is to advancing excellence and equity, and to develop solutions to catalyze change. And the model of interdisciplinary collaboration is really a winning model. It's really something that changes what we do. And I had to say, my main message to you is that I'm proud that our school, the Harvard Chan School, can be part of this and can support this program. To that, I wanted to share that I recently been a relatively new dean, a little more than 1 year into the job, that they feel already like 20, I have to say. I'm telling everyone I'm becoming a super dean because what happens the last year really created a lot of experience that I wouldn't have had otherwise. So the vision that I enrolled for our school is a vision that we call the AAA, like AAA rating for a financial institution or a country. And the 3 A's are agile, accessible, and accountable. And I have to say, I see all these 3 qualities in the Institute. An institute that's agile to tackle the most important issues globally, an institute that is accountable, porous, so that the world can come in and we can be in touch with the world, and accountable to all the people who work with us, and especially accountable to our mission. The mission to make the world a better place, which is the mission that brings together all of Harvard, but especially the mission that makes the Institute and the School of Public Health particularly close. And another thing that really has made me very proud is the new program for visiting research scholars. And I know that you welcome the political scientist from Peru and the bioinformatician from Botswana on campus for 6 weeks. And not only I think these programs are incredibly important, but I have a personal love for this because the first time I came to this campus was as a visiting scientist about 20 years ago now. And it really changed my life. It changed my career. It created so many ideas for me as an Italian early career scientist visiting Harvard back then. And I hope people also learned a little bit from me, which is the reason for having this type of exchanges, to be completely bidirectional. And of course, I mean, it ended up with me at some point being asked to come back as a faculty. That really changed my life for good. And so really proud of this. As something, since I'm the last speaker of the day, I want to make sure you probably already saw this and you were told that the show doesn't end here. Tomorrow, on the back of the program, there is a Harvard Global Health Research Showcase where starting at 10 a.m., which is for student research. And I looked up some of the students that are presenting tomorrow. One student project considers how a mental health app or apps for mental health could be a cost-effective approach to addressing needs in the Global South. Another is about surgical care in China and how people-centered care principles can be implemented to create more equitable outcomes. And the third, pretty intriguing to me, is to explore how whether AI-generated synthetic patients, and I suspected I should know that we can create patients that are synthetic today, but didn't occur to me until today, could be used to democratize access to clinical trials and promote more inclusive medical research. So these projects, in a world where there are a lot of concerns, really give me hope and optimism, and I'm sure they do the same to you. And I hope we will have time tomorrow to congratulate these young scientists and to enjoy their projects. I'd like to close here, and I want to really thank you and congratulate for your commitment to this important, incredible work. And you come from many disciplines, from many backgrounds, and for many nations. We talk a lot about how we are enriched by a diverse community, but really the key point of a diverse community is that you can have people coming together to tackle the same issue, to tackle the same issue we deeply care about, like in this case, equity in global health. It is a privilege to be here. It's a privilege to be here to celebrate, and thank you to all of you for being here, and thank you to Luis and the team for bringing us together today. And I know we have a reception, so I'm ready for it. Thank you. Thank you.
Thank you, Dean Baccarelli. I think you spoke for everyone. Everybody's probably ready for the reception. I just want to thank everybody so much for spending the day here with us in person in Cambridge. Thank you to everybody online who joined in, shared your comments, your thoughts, your questions. Thanks to the Smith Center team for everything, our AV team, the amazing team at the Harvard Global Health Institute. Thank you so much for putting this together. Our speakers, our engaged audience, you have taken me on a journey today from some despair, through worry, through hope, through intrigue, and thinking about what are we going to do in this moment? How are we going to ensure that the people we care about, the patients we care about, the communities we care about, our friends, our neighbors, our families, can be seeing themselves move forward in health is so important and ever so important. And I, for one, am really thrilled to know that I'm in a community like this that is going to persist and that will persist in the face of the challenges ahead of us. So I'm delighted to close out the day. Thank you, and please do join us for those who are here in person at a reception on the other side of the hallway. Thank you so much, everybody.